Good afternoon and a warm welcome to this afternoon's webinar on managing the needs of the allergic patient, a pharmacist's role. My name is Holly Shaw and your host for today's webinar. I work as a nurse advisor at Allergy UK. We are joined this afternoon by over 290 virtual delegates and a fantastic lineup of speakers, all experts in their field of allergy, and they're brimming with enthusiasm and knowledge to share with you, which I hope you will find both informative and interesting. I encourage you to interact and ask questions using the Slido platform, and after each presentation there will be a short 5-minute question and answer session. The following presentation I'd like to share with you showcases some of the work we do at Allergy UK and services that we offer to those whose lives are affected by allergy. So Allergy UK celebrated this year its 30th anniversary, a very special milestone for us. We are the leading UK charity covering all aspects of allergic disease. And we work closely with many allergy specialists in their field and other healthcare professionals to make sure that our clinical advice and our clinical expertise is what our service is all about and how we can best benefit those living with allergy. Next slide. So our vision at Allergy UK that no one should die of allergy. And our mission is that everybody takes allergy seriously. And through our goals to empower, educate, research and influence, we deliver a wide range of activities and services. Next slide. So why do people need us at Allergy UK? With over 2 million people living with allergic disease in the UK alone, there's a huge demand for information, advice and support for those people whose lives are touched by allergy. This could be parents of children who have allergies. This could be adults living with allergy. It might be service providers such as schools that need some expert advice with regards to caring for pupils with allergic conditions. So important that we raise awareness of the different types of allergy and how this impacts on people's lives. And we have a big role to play in advocating on behalf of the allergic community in some of the work that we do. Next slide. So how do we reach people? How do we communicate? Social media is a great way to engage with our audience, whether that's through Facebook, Twitter or Instagram. We're able to push out key messages and support those living with allergy. Next slide. So the jewel in the crown at Allergy UK, we consider as the staff here, is our helpline, which supports over 4,000 people a year through calls and its web chat facility. And this is staffed by trained helpline advisors who are supported by a clinical team made up of specialist allergy nurses and dietitians. We also extend that reach to our health advisory board, which is made up of a broad range of allergy specialists up and down the country. So if the clinical team don't know the answer to the question, we know somebody who can help. And this really does make a difference to people, especially those coming through with complex allergy needs, of which we're seeing more and more. Next slide, please. One of the services we offer as a charity is our allergy alert. So if people have a food allergy or multiple food allergies, they're able to register their details with us. And if we are provided with information by the Food Standards Agency or other food business outlets about product recalls, possible contaminations, etc., we're able to inform members of our internal database that are living with a specific food allergy of that alert. And this is one step that we can provide to help mitigate the risk of accidental exposure to a food allergen in those susceptible. Next slide. On our website, we have a broad range of digital resources to support people living with allergies. They form great resources to hand out during your consultations and conversations with patients. And we have over 70 different fact sheets on a discipline of allergic conditions. We pride ourselves as meeting all requirements for this information. It's peer reviewed clinically to make sure the information contained is accurate and clinically up to date. So I'd encourage you to explore our library of fact sheets to see if there's any suitable for those people that you support. Next slide, please. Allergy UK takes part in many surveys, research and consultations on an annual basis. We often host surveys and research on behalf of ourselves and on behalf of external stakeholders. And this helps us to better understand the need of the allergic individuals and communities that we serve. There's thousands of people on our database, and we provide the opportunity for those people to have a voice and tell us what it is that they need or what it is that they are lacking with regards to allergy services. Next slide. So we work very closely with many different external stakeholders and agencies, government departments, to make sure that we are the voice of the allergic community. It's really important that we work closely to extend our influence and bring about positive change for those people who live day to day with the impact of allergy. Next slide. So we have a dedicated section on our website for healthcare professionals. Maybe you've explored this before, maybe found this webinar advertised on there. If not, I encourage you to have a look. There's lots of different resources and information that can be of use to you in clinical practice. One of the things that we pride ourselves on is our biannual publication called Allergy Today. It's written for healthcare professionals by healthcare professionals, leaders in the field of allergy and immunology. And we have a spring, summer, autumn, winter edition, past copies available on the website, and some really great articles in there, great for professional development. We work closely with the British Society of Allergy and Clinical Immunology, which is our peak professional body here in the UK for allergy. And there's lots of great information on our website about other things that we're involved in or other services we can offer. So please do explore the website at a later date. Next slide, please. So this webinar will be available for on-demand viewing after the event. It will be posted on our website, and you will be able to claim CPD points for your attendance today. Next slide. So the running order for this afternoon's webinar is composed of 4 presentations. We'll be starting shortly with a presentation on food allergy and anaphylaxis. After our second presentation, we have a short break of 15 minutes. After that, we'll return for 2 more presentations, and this webinar will close at 16:20. At the end of each presentation, there'll be the opportunity for the questions that you post on Slido to be posed to the presenter, and we'll try to answer as many questions as is possible. So without further ado, I'd like to introduce our first guest speaker of the day, Dr. Helen Howes. Dr. Helen is a GP with an extended role in allergy. Thank you, Helen.
Thank you very much. Right, let me try and share my screen. This is always the telling moment, isn't it? Screen share. Let's see, sorry. There we go, hopefully this works. So thank you very much, Allergy UK, for inviting me to talk. I'm always really happy to come and talk for the charity. I think it's a brilliant charity, and I frequently tell my patients about it. These are my disclosures. So essentially I'm sponsored by lots of different people to give up my time to come and lecture. And a little bit more about myself. So like many people that are involved in allergy, the primary reason that I became involved in allergy is because my elder son, Ethan, who's 12 now, had milk and nut allergies when he was little. And I am a GP, that's my first and foremost role. And I quickly realised how very little I knew about allergy and made lots of terrible mistakes in his care, and would take him along to his consultant who would say things like, well, why on earth did you do that? And I would be like, oh, I didn't know, sorry. And he encouraged me eventually to go on and do some further study. So I did the Masters at Southampton University, which is a brilliant multidisciplinary course. Lots of people from all sorts of professions and countries go there. And then I started working with the paediatric allergy team at Southampton Hospital, which I did for 4.5 years. Since the pandemic, I've mostly focused my work back on being a GP, where obviously I see still lots of allergies, and pick up lots of undiagnosed allergies, and often find people who are struggling. And those families are always really grateful if you've got any extra knowledge. And I know certainly all of us in primary care would welcome any support that you could give us pharmacists to help us manage allergy. And it may well be after the lectures today that you're perhaps a little bit more knowledgeable than some of those GPs. So do share your experience that you learn with us today. And I used to chair the British Society of Allergy and Clinical Immunology for primary care. So there are quite a few specialist GPs across the country now, about 30 or so, which is quite a lot in the field of allergy. But we welcome more people. And if you're involved in allergy and you're a pharmacist and you want to get involved in that group, then do let me know. So in this brief time I have, and I do tend to talk too long, so I shall try and be good. We are going to have a look at IgE and non-IgE mediated allergy. We're going to have a look at how both of those present and how we can diagnose that, sometimes with tests and sometimes without. We'll look at allergy blood tests and how you can interpret them. And then we'll think about anaphylaxis and who should be prescribed an adrenaline autoinjector. And then I know that later on this afternoon, you'll have a bit more teaching about adrenaline autoinjectors. So first of all, I start off with some definitions that I find quite useful when I'm talking to patients and explaining things to them. You may have experienced yourself and be aware that, you know, really lots and lots of people think that they have allergies themselves or that their children have. And when we've defined that in studies, we can see that, you know, it's a big problem that about 25% of caregivers believe that their children have a food allergy, and the reality is it's more like sort of 3 to 5%. So takes quite a lot of work in primary care to unpick, you know, who is actually allergic and who isn't. And the primary thing that everybody wants is that you listen to them properly and that they feel heard, and that you're not just immediately dismissive of their symptoms. Sometimes we all know, you know, we think, oh, this just really isn't allergy, but you need something behind you to explain that to the person and then give them an explanation for what is going on instead. So hypersensitivity is just the umbrella term that we use to refer to an unpleasant but reproducible reaction to food. And then I say to patients, we call it food allergy if the immune system has become involved. So if the immune system has essentially gone awry and is reacting to something which should be harmless, like grass or milk or peanut, then we call it food allergy. And broadly speaking, that separates into IgE and non-IgE mediated food allergy, although some people will have mixed forms. And NICE have very clearly defined the different signs and symptoms associated with allergy, which we'll look at in a minute. And then there are often other key bits in the history, such as the timing involved. So how quickly after eating the food did the reaction occur? How long did it last? That point us in the right direction of whether or not it's allergy. So sometimes I'll say to a patient, look, you know, I do believe you, this is definitely happening to you or your child, but it's not a food allergy because you don't have these signs and symptoms, or this bit of the timing isn't quite right. And therefore we know it's not an immune system reaction. Therefore, you probably have an intolerance. And the true definition of intolerance is a reproducible adverse reaction that doesn't have an established immunological mechanism. So sometimes we'll know what it is. So it might be lactose intolerance, where you're lacking the lactase enzymes. And again, they get very specific symptoms of gut involvement. But sometimes we don't know the mechanisms involved. And I'll say, look, you know, and it is a bit of a get out of jail card. This is definitely happening to you. We can see that you keep getting this reaction, but it's not allergy because it doesn't meet these points. And sometimes you can follow up with, and therefore you're not at risk of anaphylaxis, so you don't need an adrenaline pen, because that's often their worries, but it's probably an intolerance, and you can lead on from there. So these are the different signs and symptoms. So we'll break them down. So if we look at the IgE mediated allergies, which are the ones that most people have heard of and are often quite easy to spot because they come quickly after exposure to the food you're allergic to and they go away quickly. So you get pruritus, so itching, erythema, which is redness, urticaria, which is hives, and angioedema, which is swelling. And they quite often get a pattern of the urticaria developing around their mouth and on their hands, where they've basically had contact with the food, and then it spreads out more widely from there. Quite often in littlies and sometimes in adults, people get what we call spontaneous urticaria, which when it only lasts for a few weeks is often triggered by an underlying virus. But some people can go on and have a chronic condition where they keep getting hives and swellings without any linking to food or other allergens. And it's not actually an allergic process that's going on, but it causes a lot of distress to patients. And generally, they get really big plaques of urticaria that occur often all over their trunk to begin with, rather than this pattern with food that's from the mouth and the hands and spreads out. With non-IgE mediated allergy, they may get itching, erythema, and eczema. And the thing to know with non-IgE mediated allergy is generally these are infants that present early. So usually about 2 to 3 months of life they present. The commonest things to have the non-IgE mediated allergy to is milk and maybe soya. And therefore they present early because they're fed early in life. So quite often it occurs for a formula-fed infant. It is less likely to occur for breastfed infants, but can still happen. Or you may find that whilst that infant is breastfeeding, they're okay, but when they're switched on to bottles or when they start to wean, that's when the problem occurs. So it presents in the first year of life, but usually the first couple of months. So they get early onset of eczema in association with lots of other symptoms, which we'll talk about. And what you find is that the eczema is difficult to manage. So everyone believes that their eczema is due to food, it would seem. And actually the Cochrane studies have shown that you have eczema first, and because of that defective skin barrier, you are more at risk of food allergies from forming. So they're at higher risk of IgE, egg, and peanut allergy from forming. But actually, the eczema itself is not caused by food. So it can be worse with some foods that have histamine in, like tomatoes and aubergines or citric fruits. And it is difficult to control if they have a coexisting non-IgE mediated allergy. Even if you remove the food that they're allergic to, like milk, they will still have eczema. It's just, it becomes much more easy to control. So certainly we don't want foods cut out of a child's diet purely for eczema reasons. It has to be very carefully considered, really. When you look at gastrointestinal, so for the IgE mediated, they get swelling within their mouth. They may get itching within their mouth, and little ones quite often describe food as tasting spicy or spiky, and can push it away with barely taking even a bite because they're aware that it's got something in that is not quite right, and adults will say the same. So it's important to watch them around food. And they may get immediate onset of tummy pain, vomiting, diarrhea. When you look at non-IgE mediated allergy, it's a really gut-heavy illness, and a lot of these symptoms will cross over with symptoms that babies can present with anyway for something called a functional gastrointestinal disorder, which is essentially a disorder that is like colic or reflux that is almost normal for babies. Over 50% of infants will experience them, and they will improve with time. And so it can be hard to work out whether they've got just a functional gastrointestinal disorder or whether they have a true allergy. And so what we encourage you to do is look at pattern recognition and to divide these symptoms into upper gut and lower gut symptoms. And you will tend to find that babies have some from each side, so the upper and the lower. So the upper would be reflux. These tend to be really miserable babies that scream day and night. So worth asking how many hours of a day do they cry for? And you'll find that it's hours and hours. So not just 3 or 4, but more like 12, 20 hours of a day. Really unsettled individuals. They vomit. Or if you look at the lower gut, then they may have lots of loose explosive nappies that are leaking everywhere. They may have what we call soft stool constipation. So they can strain and strain, but when they finally do go, it's loose. If they're breastfed, they may get blood in the stool, but it doesn't seem to happen for bottle-fed babies, and we're not quite sure why. And they may get redness around the bottom. And as time goes on, it may be that some of them start to refuse the food, so they might push it away or have reduced intake. And of course, if that begins to happen, they will have issues with their growth. But you can have infants with mild to moderate non-IgE mediated allergy that seem to be growing really well. My own son started with this type of allergy with milk, and he was a big fat baby on the 99th centile, no problems. but he was still miserable, explosive nappies, early onset eczema. So they have lots of different symptoms. So involvement of those different systems, it's important not to falsely reassure families that there's no problem when there could still be eczema, could still be allergy. It's only those with the severe non-IgE mediated allergies which will have impairment of their height and or their weight. So. And then finally, when you look at the respiratory system, for IgE mediated, they might have what looks like hay fever on exposure to the food that they're allergic to, so runny nose, congestion, sneezing, itchy eyes, or potential signs of anaphylaxis, so coughing, wheezing, breathlessness. And according to NICE, there are no non-IgE mediated symptoms associated with the respiratory system. But if you look at the MAP or the IMAP guidelines, which are the International Milk Allergy for Primary Care guidelines, they do recognise that these babies are often really snotty and congested, and that was my own experience. So with IgE-mediated allergy, it is easy to spot. This happened with my son. I gave him some cheese. He immediately swelled up, got hives, vomited. It was very obvious something was going on, and that was linked to the thing that I'd just given him. And it went away very quickly. So it comes within minutes to an hour or two of exposure to the food, and the symptoms will have completely resolved within a couple of hours. And it happens every time they eat that food. With non-IgE mediated allergy, it's harder to spot. It's a much more insidious onset. It can occur, a few hours or even day or so after eating the food. And it has to be about pattern recognition. So being aware. The commonest way these babies tend to present is they come in with either gut symptoms, vomiting or reflux, a crying baby consultation, eczema consultation, or maybe a snotty baby consultation. I would just encourage you that when you get those infants to run through what the different signs are. So if they come in with eczema, what's their gut like? What's their height and weight like? Are they congested? And if they have multiple symptoms, it just raises the awareness that this might be non-IgE mediated allergy. And if you get into the pattern of asking those questions, then you're less likely to miss this allergy, which is notoriously diagnosed late. So one of the definitions of anaphylaxis, severe life-threatening generalized or systemic hypersensitivity reaction. The definitions vary from country to country and society to society, but this is often one that's used and well recognized. And because of that challenge with definitions, there can be variable reports of when anaphylaxis has occurred. So true rates of anaphylaxis are quite difficult to track, really. Signs and symptoms, we always encourage you to think about A, B, C, D. So A for hoarse voice, so the baby's cry or the person's voice might go hoarse. They get a cough, which sounds a bit like a throat clearing cough, which like it keeps going. So it's not just once or twice, it's continuous. And they may get sensation of something being in their throat, which is a tricky one to pinpoint, whether that could just be anxiety. But in the first instance, we ask people to consider anaphylaxis, and we can unpick later on if it keeps happening, whether it's anxiety around food or not. B is for breathing, so breathless, wheezy, might have a drop in saturations. Usually that's the one that people report. They'll say, well, there was no problems with the breathing, but they miss the problems with the airway. So unless you specifically say, did their voice go hoarse or were they coughing, you will often miss some of the more subtle signs of anaphylaxis. In fact, that's how my own son presented with anaphylaxis, with a constant cough. And at the time, to me, it didn't even cross my mind that that was anaphylaxis. I just thought his allergy was slightly different. But of course, it does imply airway narrowing, bronchoconstriction, and needs to be treated with adrenaline. C for circulation. So little ones often go quite floppy. Older people might tell you that they feel faint. And of course, if it's really severe anaphylaxis, they may have tachycardia or a drop in their blood pressure or become unconscious. And D is for deterioration. So if the symptoms continue to keep getting worse, then think about anaphylaxis. These are the main things that cause food allergy. So this is 90% of what we would see. So eggs, milk, soya, peanuts, tree nuts, fish, shellfish, gluten and wheat. We do see much more things coming through, particularly as we've all started to change our diets and want to do things like be wheat-free. We start to use more things like lupin flour, and then we get adults who are now reacting more to lupin. With the craze to kind of go more meat-free, we're using foods like jackfruit, and then some of my colleagues are seeing some more unusual allergies to jackfruit, which was not something that we really had very much of in our country. So you can be allergic to anything, but these are the commonest things. And, in children, we don't often see allergies to spices and things. So I just encourage you to think common things are common. if somebody's coming in with no history of problems of eczema, asthma, hay fever, food allergies, and they're looking through random packets to think what might have triggered a reaction, there's a possibility that their reaction is actually caused by a virus or is spontaneous. So just take time really trying to unpick that history. So we're going to use a couple of case histories to demonstrate. So Flora is 9 and brought by her parents who are concerned about a peanut allergy. She used to eat peanuts regularly as a toddler, but stopped at some point when she became a bit fussy and hasn't knowingly eaten them until she tried a chocolate bar containing peanuts yesterday. And you hear that within 15 minutes, she developed urticaria around her mouth, angioedema of her face, and vomited. And when you specifically ask, Mum tells you that she was coughing and her voice went hoarse. They had some antihistamine, some cetirizine in the house, so they gave that, and her symptoms went away after 30 minutes. And actually, she does have an atopic history, which we would ask, so she has well-controlled eczema and asthma. And when you ask about family history, and we ask about first-degree relatives only, so mum, dad, and siblings, both of them have some atopy themselves. So having a think to yourselves, what do you think is the most likely cause of Flora's symptoms? An IgE-mediated peanut allergy, non-IgE-mediated peanut allergy, or a viral illness? And hopefully after what we've discussed so far, you're thinking this sounds like it's probably an IgE-mediated peanut allergy. And just to recap some of the signs and symptoms, so when we looked at the skin, she had urticaria and angioedema. For the gastrointestinal, she had immediate onset of vomiting. And actually when we asked, she had some signs of lower respiratory system involvement with the coughing and the hoarse voice. It came quickly after eating it and it went quickly. So that's classic of IgE-mediated allergy. If someone's telling you their symptoms lasted for days, then you need to think this is an allergy. This may well be a virus or spontaneous urticaria. And we don't know about the reproducibility, but what very often happens with peanut allergy is that children may well eat it very regularly when they're little. And when they become fussy and they've had years of not eating it, they lose their tolerance. And this particularly happens in those with eczema. And we've learned about it from one of the studies called the LEAP study, the Learning Early About Peanut study. And what we know is that in children with eczema, they need to be eating it regularly twice a week before the age of 1 in the form of a paste or a butter so they don't choke until the age of 5 to maintain their tolerance. So this is a classic story I hear in clinic that someone was able to eat it, but because they stopped and didn't eat it for years, on their next exposure, they then had an allergic reaction because they weren't eating it consistently. So this is a classic history. If Flora had said, my symptoms lasted for days and I had a bit of a fever and a cold, then you're going to say, okay, it's much more likely that this particular symptoms were triggered by some sort of virus you had at the moment. But it can be difficult to pinpoint between the two, and sometimes you have to go on and do testing to be sure. So how do we confirm the test? So the only validated ways of confirming IgE-mediated allergy is with a skin test, which are usually done in secondary care clinics, a specific IgE blood test, which we can do from primary care, or a hospital food challenge, which is for a few people. There are other allergy tests, which you will see advertised on the market, like hair analysis, patch testing, which is used by dermatologists to look at more delayed skin reactions, so type 4 reactions, not the food allergies that we're talking about. Sometimes people will tell you they've had blood tests to diagnose their allergies, but when you look closer, you can see they had an IgG, not an IgE, and that's not a validated test. Or they might do crazy things like hold on to bars, electric bars, and have things tested. And essentially what they always do on the high street is tell people that they're allergic to all the things that cause irritable bowel, like wheat, dairy, milk, eggs and spices. And to cut those things out as an adult is fine to some extent, but when people are cutting those things out as a child, it can really cause nutritional deficit. So explain to your patients those are not validated tests. And there's a really useful leaflet I've put at the bottom from the British Society of Allergy called Choosing Wisely about tests. I'll talk a little bit more about each of them in a minute. But I just wanted to explain to you about why we don't just do allergy tests on everyone that comes through the door. So when the body's exposed to an allergen, it's exposed through one of 3 ways, either through eating it, so through the gut, through that defective skin barrier that we've talked about with eczema, or by inhaling it. And when that happens, the body does one of 3 things. So one would be absolutely nothing. So for instance, they eat peanut, there's no problems, and you might check an IgE blood test of peanut, and it will be negative, which is less than 0.35. And that's lovely. On the other end of the spectrum, you might have someone that says, every time I eat peanuts, I get hives and swelling and vomiting, and it comes quickly and it goes quickly. And you check their IgE to peanut and it's over 0.35, so it's positive. So that fits with a history where you're already suspicious of allergy, and the blood test is just confirming what you were already suspicious of. The group we're wary of are the group in the middle who produce enough IgE to make a positive test, but don't necessarily have allergy going along with it. And they're what we call sensitized, and this is notorious for those with eczema. And they can produce really high IgEs on the blood test. So the highest it will go to is over 100. And they can have IgEs of over 100 to lots of things. And sometimes I have found that people who don't understand allergy fully, so possibly in primary care, sometimes dermatologists, will do panels of food tests. So just randomly checking lots of different foods to see what people might be allergic to, in inverted commas. And the classic reason people have it done is because they've got eczema, which isn't very well controlled, and everybody wants to know what food is triggering it. And as I said, that's not the case. So these blood tests should only be done if you have IgE symptoms. And you will recall that the IgE symptoms were hives, swelling, vomiting, diarrhea, upper respiratory, hay fever type symptoms, or anaphylaxis, not eczema. So if you do an IgE to something, so for instance, I had an eczema patient, she had a panel done, it was positive to all the nuts. So she came to see me in clinic, and there was quite a delay because we do have quite a long waiting list. And I said to her, okay, did you ever used to eat nuts? And she said, yeah, I did all the time. And I said, did they ever cause hives, swelling, vomiting, etc.? No, she said. I said, did you eat them regularly? She said, yeah, we really loved them as a family. We ate them all the time. So all that blood test had shown is that she was sensitized to nuts, but she wasn't truly allergic. The risk we then had with that patient is because she'd cut them out of her diet for quite a long time, because it took her a while to see me, she could well have lost her tolerance, as I've demonstrated with that case, and allergy could then form. So it really isn't a safe thing to do, to just tell people to cut things out of their diet based only on a positive test without a correlating history. I managed to get all the nuts back into her diet, and thankfully she was fine. There was no change in her eczema. The test shouldn't have been done in the first place. So think carefully about who you're doing tests for. So I've already said you can request the IgE blood test on your ICE system if you're able to. It comes back as a number and as a grade 1 to 4. And all we're really looking at is the number. For all tests, you cannot predict the likelihood that someone's going to have a severe reaction. So as I've said, my son Ethan has had several episodes of anaphylaxis. His IgE to milk was only about 6 to 8, and it can be over 100. You can't predict, unfortunately, when anaphylaxis is going to occur. The higher the blood test we use to help us work out how likely might this person be to outgrow it, and we use it to track, is the allergy seeming to resolve. We don't use it to predict whether there's allergy there in the first place, as I've said, if you're sensitized, or whether you're likely to have anaphylaxis. So just pick carefully what you want to do. You can do it to aeroallergens, so you can do it for house dust, mite grass, tree pollen. That's fine to do a panel of those things if you are suspicious, but not for food. In allergy clinics, they might do skin prick testing. This works really well on any age. There's no lower limit. We just would only do it if that person's actually consuming the food. For the skin prick test, they have to have stopped their antihistamine for 4 days before they come. That's not true for blood tests. They can stay on the antihistamine. So if you can't get someone to stop antihistamines, we would do a blood test. Children and babies tolerate this really well as well. Basically, we have little solutions that contain different things like milk, egg, grass pollen, cat. You pop a little droplet on their arm and you prick their skin with a lancet. So it feels a bit like they've poked their skin with a sharp pencil. You wipe away the solution and we wait 15 minutes and we're looking to see whether they get a little hive there, essentially. If it's over 3 millimeters, we call that positive. It's a nice thing to do because people get answers on the day, which families usually really like. Things are a bit different, obviously, because of COVID. We used to run what we call one-stop allergy clinics, where people would come in, see the allergist, have a full history, then skin prick test if they need it, then see the consultant, and then see a dietitian if they needed it. And of course, with limitations of coming in, you more often than not find that people are having a history at home and then being called in for skin prick tests and then having a separate follow-up with the dietitian. So it is more disjointed, unfortunately, than it used to be. The other thing you can do is if we don't have the solution, we can do things like, for instance, prick a kiwi and then prick their skin. So we get, there's a wide range of things that we can test for, but isn't usually done in primary care. And then finally in hospital, if we were really in doubt about allergies, we can do a food challenge. So the person comes in for half a day, you give them increasing amounts of food that you're suspicious of. So by the end of that half day, they hopefully, if they've passed the challenge, will be able to eat a normal sized portion, say, of egg for their age. If at any point they react, obviously the test is stopped. It's treated appropriately, either with antihistamine or adrenaline. And if they need adrenaline, we quite often encourage the person or the family to give the adrenaline auto-injectors themselves so that they get the experience and support in that kind of supported environment. We do it for a few reasons. So we do it if somebody did have an allergy and now their blood tests and skin prick tests look negative, and we want to see, have they outgrown it for sure? So we do it to show safely that they actually now can go on and eat this food. We might do it if the blood tests and the skin tests are negative, but we're really suspicious from the history that they actually are allergic to it. And this notoriously happens with sesame. Then we might do a food challenge to show one way or another, do they have an allergy? And then very occasionally we do a demonstration challenge. So sometimes we have quite difficult teenagers who don't believe that they have an allergy, either because they've only ever had positive skin tests and never had an allergic reaction, or because they did have an allergic reaction, but it was so tiny when it happened, they don't remember it. And now, despite us saying, look, we think you've got an ongoing allergy because the blood tests are still positive, your skin tests are still positive, they might say, for instance, well, I don't really believe you and I'm going to go and eat those peanuts, or take risks. And if we deem that the risk of them doing that in an outside environment is higher than the risk of a food challenge, then if we consent them properly, sometimes we decide to do a demonstration challenge in hospital. And occasionally they pass it and they were right and they have outgrown it and the tests are just falsely positive. But otherwise, then in a supported environment where we could more safely treat them, we're showing them that, look, this food is dangerous, and then they tend to believe you from there. It's only done rarely, but it is something we can fall back on. So thinking about Flora's case, thinking in yourself, do you think she should be prescribed an adrenaline auto-injector? And the two that we have available now are EpiPen and Jext, and both come in the 150 and 300 microgram dose. And the answer is yes. And often people say to me, well, can we do that in primary care before we've even seen secondary care? And the answer is yes. But you should refer them on. That's the nice guidelines if you think that they've had anaphylaxis. And if in clinic they come to see me and I say, well, do you know what, actually, you didn't need an adrenaline auto-injector because X, Y, and Z. It's not a big deal. We would just say, next time, don't renew the prescription or hand it back into pharmacy. We're certainly not going to tell somebody off. These are the British Society guidelines for prescribing them, so they're a bit complicated and you can look at them in your own time. But essentially, if you've ever had anaphylaxis to food, then you need it. Or if you have asthma and an IgE-mediated food allergy, then you need it. Just to go over that a bit more. And that's because if you have asthma and food allergies, you are at higher risk of anaphylaxis from occurring, particularly if your asthma is poorly controlled, especially then on a day you're exposed to the food. If your asthma is bad, you're more likely to have anaphylaxis. So, and we have seen that the deaths from anaphylaxis often occur in asthmatics. So if someone has spontaneous anaphylaxis, these more unusual things, exercise-induced anaphylaxis, asthma and IgE-mediated food allergy, significant venom allergies, so bee and wasp allergies, or mast cell disorders, they should be given an adrenaline auto-injector. There's then a group in the middle that there's no right or wrong answer, and it's being led by the patients and having discussions with them, as we do all the time, that, you know, if you've got a super anxious person in front of you that says, I'm never going to go to a party or eat out without it, then you may well want to consider an adrenaline auto-injector for them. We used to say for those with peanut and tree nut allergies, because they were at higher risk, we saw of them dying, that we would consider giving them one, and particularly if school-aged. And teenagers and young adults, also a group that are at higher risk of anaphylaxis and death. But if that person's saying to you, well, I'm never going to carry it, you know, as long as you've had very clear discussions about why you would want them to, the risks involved, then there is no point prescribing it if they say it's not coming out with me. You know, it has to be a two-way conversation. If they're going to the middle of nowhere, or if they've only ever reacted to trace amounts of foods, then again, you may well want to prescribe it. But it isn't needed if you have a drug allergy. Just very briefly, if you think about it sensibly, even if someone's had a really severe allergy to, say, penicillin, where they've been on intensive care, whenever we prescribe, we're going to say, are you allergic to anything? And they'll say, yes, penicillin, so we won't give it to them. If they're unconscious and someone comes along and they're a paramedic and they want to give them penicillin, then they would hopefully recognise that person's having anaphylaxis, but certainly would have adrenaline with them that they would then be able to treat. So sensible for drug allergy patients to wear an alert bracelet, especially if they have significant allergy, but we don't need to prescribe them adrenaline auto-injectors. If they have bee and wasp sting allergies and they've had immunotherapy, so they're not allergic anymore, they don't need it. The easily avoidable food, again, I think is a bit questionable. Nothing is actually as easy to avoid as you think. So take that, think carefully. As I've said, you can't predict anaphylaxis, unfortunately. It is more likely to occur on a day you're poorly if you eat the food you're allergic to, or with your asthma. But otherwise, when we look at deaths that occur, and thankfully they are low, about 30 a year. So it is low, but if it happens to you, it's devastating to you or your family. About 50% of fatal reactions did occur in those that had only ever had mild reactions. So you can't say to someone, oh, you've only ever had hives and swelling, that's all that'll ever happen. With my own son, that was all that ever used to happen to him. And then one day, anaphylaxis. You also can't say your reaction will get worse each time you're exposed to the food. That's not true either. So just be very cautious. We have seen anaphylaxis rates triple in the past 20 years. We've also seen prescription rates increase, and thankfully deaths from anaphylaxis don't seem to be increasing. So whether that's increased awareness and adrenaline prescriptions, we don't know. It's very hard to correlate. I'd like to think it's education, but we still know lots more needs to be done on the education front. The interesting thing we've seen is that in younger children, actually deaths now are on the increase from milk allergy rather than the nut side. So something to be very aware of. I think because milk allergy is so common, because of this difference of the non-IgE mediated milk allergy, there's a lot of negative press about overdiagnosis of milk allergy. And if you have a child with an IgE mediated milk allergy, it is very significant. It's easy to have contamination in coffee shops. Milk can be aerosolized and cause reactions. Be very aware, it can be very problematic. Other bits of information we should give people, so about eating out, about useful charities that they can contact, about how to recognise allergic reactions. Foods are labelled in bold on the back with some of the main allergens, so I tell families to always check the packet even if they've eaten it before to see, does it contain the foods that they're allergic to. I also always print them off an allergy action plan. So if you go to the British Society website and in the search engine write action plan, you'll find 3. One for EpiPen, one for Jext, and one for no adrenaline auto-injector. They only have them for peds, but they do work for adults, so I give them to adults as well. They're quite self-explanatory. It tells you what a mild to moderate reaction looks like, and therefore what antihistamine to take, and what anaphylaxis looks like, and a reminder of how to use the pens. You sign it at the bottom, and it means that they can give those action plans to school, to nurseries, take on board the plane their adrenaline with them. Make sure you know how to use them, and direct patients and families to the product website where there are videos they can watch, various apps that they can use. So whenever you prescribe an adrenaline auto-injector, it has to come with training, and you and they can get hold of dummy devices to practice on. You just ask the manufacturers, but it works very well across video consults to train them. Obviously, we're doing lots of things remotely these days. It works really well for allergy. You can do a really clear allergy focus history across computer. Just make sure that you're seeing those children. We always have to be aware of safeguarding when it comes to children, particularly, food is actually often a way that safeguarding issues come to light when things are going on at home. I've had several quite big safeguarding cases come up where it was the food being controlled. So just be aware of that. Be aware that if children will need to be examined. So if you're concerned about non-IgE and constipation and vomiting, you need to feel that child's tummy. We did have an unfortunate case where a child was diagnosed with non-IgE mediated allergy and actually had a Wilms tumour because nobody felt their tummy until it was a bit late. So do examine them, but remote consultations definitely have their uses as well. And I've touched upon who to refer. So if you have IgE mediated allergy and asthma, refer them. Anyone with multiple food allergies needs dietetic involvement and help. Faltering growth, of course, anyone with anaphylaxis. For the eczema, if they are concerned about allergy, restricting foods, or babies, then refer them to us. If it's just difficult to control eczema, then think about a dermatologist. And parental suspicion. So as I've said, it's important to make sure children aren't having restrictive diets. So sometimes it's just as important to see an allergist to unpick that information. as it is to not see them. So I know I'm running out of time, but just briefly, a little bit about non-IgE mediated allergy. So Sarah's a 3-month-old baby, born at term, but needed IV antibiotics due to aspiration and meconium, and she's formula fed. And within 2 months, her parents report that she's got widespread eczema, really unsettled baby. And you can see she's been to A&E lots, GP lots, health visitor. She vomits lots and has lots of frequent explosive nappies. So hopefully from that history, as we've talked about, you're thinking to yourself, okay, maybe this is the one she said about the non-IgE mediated cow's milk protein allergy. So to recap for the skin, Sarah had early onset eczema. She was vomiting, so she had upper gut symptoms. She had the lower gut symptoms of lots of loose explosive nappies. It didn't mention the congestion, but you can ask, is she a kind of snotty, grunty baby? Check her height and weight. And again, these symptoms occur every time they're exposed to the food, but the timing is hard to work out with non-IgE mediated allergy initially because it happens because babies are feeding all the time. So it's hard to say. It's always, 1 or 2 hours later. What families tend to find is when the food is cut out, when it's put back into the diet, they'll say, oh, it's always 14 hours later or so that baby gets the symptoms. I've mentioned the challenges we have with the diagnosis because for non-IgE mediated allergy, there is no test that exists. There's no blood test you can do to diagnose it. It's about pattern recognition, cutting the food out and then retrying it to confirm that the symptoms come back. It crosses over with these functional gastrointestinal disorders, which are a group of disorders which have no structural biochemical abnormality like colic, reflux, diarrhea. They're managed with practical strategies in primary care. They do outgrow them, but you can see when someone's got multiple issues of functional gastrointestinal disorder, then often that could actually be undiagnosed allergy. So you say to Sarah's mum, I think she's got a non-IgE cow's milk protein allergy, and you prescribe her because she's formula fed an extensively hydrolyzed formula. These are the indications for amino acid formula. So issues with growth, severe eczema, perhaps that they're on moderate strength steroids without any improvement, anaphylaxis. If a baby's had an extensively hydrolyzed formula and got a bit better, but not fully better after 2 to 4 weeks, then we would try an amino acid formula. If they are multiply allergic, or if they have some of these rarer gastrointestinal symptoms that I haven't gone into, which is food protein-induced enterocolitis syndrome and eosinophilic esophagitis. Quite complex. There will be sheets on Allergy UK about them, but those are the indications for amino acid formulas. They cost over double the price of an extensively hydrolyzed formula. And there is some thoughts that it delays the time for children to gain tolerance to milk. So please use the correct formula if you're prescribing. And you will find more about it on the International Milk Allergy Primary Care Guidelines. So those IMAP guidelines I said, or probable local feeding guidelines, like we've got Wessex feeding guidelines that tell you more about it. So last few slides. So Sarah's mum comes back after a month and says she's much better. So what do we say? Do we say, okay, she's got a milk allergy, we'll keep prescribing the formula for you? Or, right, I'm going to refer her to an allergist or a dietitian? Or do we say, okay, now we have to retry the old formula? And hopefully you are hearing me say that we need to retry the old formula. And that is because it's the only way we currently have of getting the diagnosis correct. So the recommendation is that you do an exclusion diet if you're suspicious of non-IgE mediated allergy. So you cut the food out for 2 to 4 weeks. So if it's a breastfed baby, mummy cuts milk out. If it's a formula-fed baby, put them usually on an extensively hydrolyzed formula. If there's no improvement at all, think whether you've got your diagnosis right. If they've got a bit better, you might need to switch them onto an amino acid formula. And then when they're completely better, we need to show that this was definitely milk allergy, not just maybe a functional gastrointestinal disorder that's resolved, or not just baby having a funny 5 minutes, because nobody wants to give their child a restrictive diet unless they really need to. It causes lots of psychological concerns for the child and the family as they grow up, and also could mean that child is prevented from gaining tolerance to these things. So they must retry the formula, or mums put milk back into their diet. And if the symptoms all come back, it confirms the diagnosis. And at that point, NICE recommends that for the mild to moderate non-IgEs, they're referred to a dietitian for support. And for the more severe ones, that's the one with impairment of growth and weight, really, then they would be referred to an allergist or a paediatrician with a specialist interest. And then the food is normally cut out for 6 months and then slowly introduced with milk ladders. And again, there's more about that on the Allergy UK or the MAP International Milk Allergy for Primary Care guidelines. Babies only need to cut back a bit of milk. So if they've just tried, just one bottle and mum says all the symptoms have come back, that is enough to make your diagnosis. But it's a bit like celiac disease. We wouldn't diagnose celiac disease without the blood tests and the gastroscopy while someone's on wheat. It's the same thing for allergy. You have to diagnose it correctly, and that means they do have to retry the foods. So in summary, IgE-mediated allergy, generally is quite easy to spot and diagnose. It comes quickly, it goes quickly, very quickly after eating the food. It's reproducible, usually to classic things. And we have the nice allergy testing, which we can do to confirm what we're suspicious of. Non-IgE-mediated allergy, be aware of those consultations, ask the correct questions. So what's their gut like? What's their skin like? What's their respiratory system like? Are they growing well? Have it on your radar. Cut the food out for 2 to 4 weeks and then retry it in order to confirm it correctly. Sometimes this is where food diaries come in helpful for the non-IgE mediated allergies, for families to write down what's happening and correlation, and that can help us work out a bit more what's going on. I'm sorry, I know it's a whistle-stop tour and I know I talk quickly, but hopefully you'll get my slides if you need them. So I'm happy to answer any questions.
Thanks so much, Helen. As you say, so much to fit in such a short presentation, but you did an excellent job of taking us on that journey and differentiating between the two main mechanisms. I have a question here, and it's quite timely with the flu season imminent, and it's about the advice you can advise on a child with egg allergy, not a severe one, never needed an ITU admission, but around parental anxiety with regards to the nasal flu vaccine. So really, what advice would you give to a parent who has a child with a mild to moderate egg allergy and is considering whether to vaccinate their child with a nasal flu vaccine?
So whenever you're thinking about vaccinations and any concerns, always have a little look at the Green Book vaccinations, because it will tell you what you can and can't do. And interestingly, there was a large study into the nasal flu vaccination, which was done at Southampton. That's why probably I know more about it, which was called the Sniffle Study. And they included everyone with egg allergy, apart from those who'd been intubated on intensive care because of egg allergy, which is really, I've never seen anybody like that. And everybody was absolutely fine. So that's what I would try and reassure, that we do it. We've done it for lots. I would do it for my child with allergy. Often quite helps when you throw in that your child's had allergy, but I appreciate not everyone can do that. So reassure them there is absolutely no concerns with it. And secondary care certainly wouldn't want to be overwhelmed. But if you have real difficulty with vaccinations and you feel like it is absolutely imperative that child has a vaccination, then perhaps sometimes it's worth us seeing them in secondary care so we can try and support that family.
That's great, thank you. I think the key message is there is not to stew, not to worry, discuss it with a healthcare professional. Our helpline, we would be happy to take calls on that. Our egg allergy fact sheet discusses that very question. So thanks, Helen. That was an excellent presentation. In the interest of time, I'm going to introduce our next speaker, who is Rebecca Batt. Rebecca is an advanced nurse practitioner, and she works at the Evelina London Children's Hospital. And Rebecca is joining us this afternoon to talk about allergic rhinitis. Thank you, Rebecca.
So thank you very much for asking me to speak this afternoon. This is a subject that's very close to my heart, and I run the Severe Allergic Rhinitis Clinic at the Evelina Children's Hospital, where we have about 800 children on immunotherapy for severe allergic rhinitis. So I'm going to go through all the key things that you need to know as a pharmacist this afternoon, and hopefully there will be some time for questions. So the aim of the presentation is really just to go through an overview of the disease, to talk about some of the common airborne allergens, how we approach allergen avoidance, and what kind of measures we can advise our patients. And as well as that, going through the medical management, and because I know your pharmacist will focus on the mechanism of some of the treatments that we recommend. And then we can go through the important role that you play. So we know that rhinoconjunctivitis is a chronic, mostly eosinophilic inflammation, and of inflammation of the nasal mucosa and conjunctiva. So it affects up to 25 of the population. And really the symptoms are quite wide-ranging, can just be continuous sneezing, very itchy. You can have an watery nasal discharge, nasal congestion, and the severity of those symptoms vary according to each individual. Sometimes they're associated with ocular symptoms. The eyes can be very red, watery and itchy, and it can feel like there's a foreign body in the eye. And the symptoms can be seasonal or perennial, so they can be all year round or very specifically at one season, and we'll talk about that a bit more in a while. And again, symptoms are intermittent or persistent. So the children that we see in our allergy clinic, our severe allergic rhinitis clinic, by the time they've got to us, they have already got some association with a loss of quality of life. And some of our children actually are unable to go to school during the summer months and are missing a lot of school, particularly, say, in the grass and tree pollen season. They suddenly stop being able to sleep. They become very irritable, their concentration drops, and this can then affect their school performance, and they have a drop in their school grades. It can exacerbate asthma, and there's a huge link between asthma and allergic rhinitis. And rhinitis is present in up to 95% of patients with asthma. So when you are talking to patients over the counter, as it were, you will need to think about the effects on the lower airway. It can occur in children as young as 1.4 years, and it does depend on when the child was born. So if they were born in the spring and summer months, they've already got some exposure to that pollen, even at a very small age. And of course, what we always go back to in allergy, which I'm sure Helen just went through, is going through the history, trying to work out what treatments people have tried and how effective they were. And often over-the-counter medicines are the first line. So just again, some of the statistics, up to 30% of adults and as much as 40% of children have allergic rhinitis. And there's a huge association, like I said earlier, with sleep problems leading to fatigue and decreased cognitive functioning. So we talk about one airway, one disease. So you have to think about what you're doing. If you're breathing in something that is irritating your nose, it's very likely to be irritating your airways. And if your nose is blocked, you're not going to be able to breathe properly. So you then mouth breathe, which means you take in all the pollen and particles, pollution, and basically all the horrible stuff in the air that your nose normally filters out. And that then goes straight into your airways. So then you're likely, if you're going to be sensitized to one of these potential aeroallergens, then the symptoms can develop further down in the airway. And that's why there's such a huge association between allergic rhinitis and asthma. So some of the common triggers that we see, house dust mite is the all year rounder. So it is usually worse in the winter months because that's where we have our central heating on. Although I have to say at this moment in time, it could be pretty bad right now because we haven't had a very warm few weeks. So as soon as the central heating goes on, the windows start closing, the humidity in the house starts increasing. So we can see that all year round. But again, that's more of the peak time of the house dust mite is the winter. There is a pollen calendar, which I'm going to show you in a little while, but the grass, the trees and the weeds all sort of cross over right through really from January through to the end of the autumn. And then we've got mold and fungal spores that happen during the autumn. And there's animal dander, so we always have to think about whether the patients have animals. There's occupational rhinitis, where, for example, if you're a baker, you could have the flour that's inhaled. Latex, some of the powder that comes out from latex gloves, for example, and also there can be non-specific triggers such as smoke and dust, viral infections, cold air, strong odours. So how do we diagnose it? Exactly the same as food allergy. So skin prick test, specific IgE. We're now doing home allergy tests, which is where we send a kit home to the patients where we can do 294 allergens in one small volume of blood. And then those results get sent back to us. So although the diagnosis is is reliable because it's still an IgE test, the way we interpret those are different from the laboratories we use in the hospital. So we're having to be very careful how we interpret those. But certainly the advantages of doing the home allergy test and specific IgE in the hospital is that we can then look at the components, and then we can confirm whether somebody has a cross-reaction protein between pollen and food. And just going on to that now, we're actually seeing this a lot more in our clinics. In the time I've been in allergy, it used to be something, it used to be called oral allergy syndrome. We've moved now into pollen food syndrome. But if you're sensitized to birch pollen, if you're sensitized to grass, to ragweed, or to plane, then there's a cross-reaction with the PR10 protein that causes oral itching, oral pruritus. It very rarely goes to a very severe reaction, but it's certainly very irritating to the oral cavity. So you can eat these foods cooked, but not raw. So people can have cooked apple, but not raw apple. And that's because these PR10 proteins get broken down very quickly by heating or adding to sugar, and certainly by the time it gets to the stomach. So we're seeing a lot of patients in our clinic who say, oh yeah, I've got tree pollen allergy, but I can't eat apples, I can't eat pears, they make my lips and mouth really itchy. So a lot of foods tend to get avoided. But when we're going through a history with our parents, they suddenly go, oh, okay, that's why they don't like these particular foods. I just thought they were being really fussy, but especially raw carrot. That seems to be the one. Oh no, I'm really hoping that they would eat raw carrot. We know it's really healthy for them, but actually it really is irritating if you have this PR10 cross reaction. So rhinoconjunctivitis can be classified into allergic, infectious and non-allergic. So sort of for the purpose of this talk, we're going to be talking more about the allergic side, but just to be aware that there is an infectious rhinitis, which is usually secondary to a viral infection. And also there can be non-allergic rhinitis, which can be structural, neurogenic, hormonal, drug, irritant related. They're usually more difficult to work up. So the early phase allergic rhinoconjunctivitis is where we see just conjunctivitis. We're going to just talk about the eyes first. So these are two distinct disorders where we can see seasonal and perennial allergic rhinitis. You get inflammation of the conjunctiva, you can get increased vasodilation, itching, photophobia, and it feels like there's a foreign body in the eye. And then we come to the late stage just trying to move my late stage allergic conjunctivitis is where we start seeing problems with the epithelial cells. We know that the eosinophils are recruited, conjunctival fibroblasts are activated, and we start seeing what we call vernal keratoconjunctivitis, which is graded based on the severity, and it's very common in summer. And then we can have atopic keratoconjunctivitis, which is chronic bilateral disease, and it has no correlation with different times of the year. So you just have this all the time. These patients usually need to go to ophthalmology. So looking at our guidelines, we base our guidelines on the BSACI rhinitis guidelines that were last updated in 2017, but also on the ARIA guidelines and the South East London integrated guideline, which I'll go through in a little while. The ARIA guideline aims to educate and implement evidence-based management, and it looks at the conjunction between rhinitis and asthma worldwide. And looking at the guidelines, these are all available free. You don't have to be a member to look at any of these guidelines. They're widely available. And certainly GPs and pharmacists play a key role, because you're the people that patients often go to first. So by the time they get to us, it's more about tweaking their medication, perhaps giving them something maybe off license that isn't recommended, that other people are not prepared to prescribe or recommend, and then of course to consult for immunotherapy. But really, pharmacists and GPs are key in the first line management. So the other guidelines that are available, which I told you about, have been all pulled together, and in conjunction with the South East London group, which the Evelina is part of, we've come up with these local guidelines just to help try to spread the word really on how to classify allergic rhinitis and how to treat each stage. These are available if you just download, if you just put this search in your Google bar, this actually will all be downloadable. They're really useful tools because I think it's almost better than the other guidelines, basically because of the colour. It really can see really clearly what medication needs to go at what stage and when it's appropriate to inform patients to get referred. And then again, just it breaks down into paediatrics, adults, and also red flags for urgent referral. So I highly recommend downloading these and having them available. So the cornerstone to all management for allergic rhinitis is to control the symptoms and try to reduce that inflammation. And really, despite that, it's very hard to avoid pollens. It's very hard to avoid house dust mite. We'll talk about some of those in a little while. But that is the cornerstone, really. Avoidance is recommended in all the guidelines. Obviously, if you're allergic to cats, that's been diagnosed. If you continue to have a cat, it is going to still continue to cause issues. It's much harder to avoid pollens and house dust mite and weeds and molds. You know, these are the ones that are actually more tricky to avoid in a normal lifestyle. And then it's knowing your pollens. So just looking at this calendar here, there's a peak time, which is in the green bold there, but there's a gap. There's also gaps either side where we definitely know the pollen season can range. So depending, and this is where the IgE component testing really comes in, because we can look at what kind of protein, what kind of tree, for example, or types of grass that that patient is allergic to, and we can be a little bit more informative about when that treatment needs to start. So some patients are very allergic to or sensitized to alder and hazel and yew and elm, and so their symptoms are going to start much earlier, or can start much earlier in the year. Birch is one of the late pollens, so birch is more end of February and through into April time. And again, you know, the grass pollen season can extend all the way really from the beginning of April to the end of August, and sometimes into September if it's a warmer year. So again, it's really about knowing your pollens. So watch the pollen count. There's also pollen count apps that you can download, which are really useful, and it will send alerts to patients about when their particular triggers are peaking. You can use an air filter in the house. You can try and keep the windows closed. Use wraparound sunglasses. Shower when you get home. That washes out the pollen from the hair. You can change your clothes, and don't dry clothes on the line when the pollen count is high. But of course, this is all very well to say, but in practical terms, it's quite hard to implement. The avoidance of house dust mite, there are ways to reduce the amount of house dust mite that one's exposed to, but you can really never get away from the house dust mite entirely. Only if you are living at altitude is really the only place. So if you're up in the mountains, that's great, but otherwise we really are stuck with them. We do suggest washing duvets and bedding at 60 degrees. That kills 90% of the mites. Lower degree washing just doesn't. It washes the clothes, but it doesn't get rid of the house dust mite. Reducing the humidity in the home, reducing toys and clutter, and toys and can go in the freezer for 6 hours, and that does actually kill the dust mite. So that's quite a useful thing to do whilst children are at school. Soft furnishings. Again, these are all harbours for house dust mite. Again, so it's really about just being aware that there are ways to. Oh, hang on, my slides are all jumping ahead here. So looking at the Cochrane review. Okay, sorry, it seems to be jumping all over the place. Okay, there's also the use of impermeable covers, and if you're going to use impermeable covers, you need to do ones that are completely encasing in the mattress, not ones that just go over the top of the mattress, because the house dust might just come in through the bottom and round the sides. So when you are recommending any impermeable mattresses, it needs to be one with a zip all the way through. And then, of course, you have to hoover on top of that, because the whole point of that impermeable mattress is a cover is that it stops going through into the lower levels of the mattress. So the house dust might end up just sitting on the top of that cover. So then that needs hoovering with a high particle filter, a HEPA filter hoover. So it's quite laborious to reduce the amount of house dust mite available in the home. And the reports that have been done, there have been so many evidence-based studies looking at, is this worth it? Are all these methods really worth it? And the only thing that's got some benefit is that the mite impermeable casings can reduce the amount of children going into hospital with asthma exacerbations, but not the amount of children requiring prednisolone. So they do work, but it all has to be done in conjunction with each other. So there's some options for non-pharmacological management. So that can be saline douching, sea salt sprays. They can provide some relief, but they're not always, or they're not going to treat the symptoms, they're just going to provide some relief. There's also something called an Airsonet, which is a laminar airflow device, which you can hire. You need a pretty big bedroom for it, but it basically cools and filters a proportion of the air that the patient is lying on overnight. And that actually does have some really good benefits that have been tried and tested. So the Airsonet, if you've got the money for it and you've got the space for it, can work really well. And of course, there's complementary and alternative therapies that are available, but we don't really advise those. We obviously have to just give people the evidence and the facts. So really the mainstay of treating allergic rhinitis is antihistamines and a corticosteroid nasal spray. So we would always recommend that we use a second generation antihistamine, basically because the first generation antihistamines, chlorphenamine and diphenhydramine, cross the blood-brain barrier and can cause drowsiness. They also are fairly short-acting antihistamines, so we prefer one of the long-acting antihistamines such as cetirizine or fexofenadine or loratadine, desloratadine. So if anyone should be on anything, it should be one of those antihistamines. Now, there's some of the side effects there, although we actually say there aren't that many side effects, of course, there are always going to be some side effects with drugs, but really these are very well tolerated. But some people are still sensitive to the non-sedating antihistamines. I think it's about 1% of patients who are prescribed a non-sedating antihistamine will still feel some drowsiness with perhaps cetirizine or loratadine. So it can have a sedative effect. Loratadine can cause cardiac effects when it's taken with certain antibiotics, so erythromycin, azithromycin, and erythromycin, fluconazole, ciprofloxacin. And so these are the things that if somebody's taking any antibiotics and they're on loratadine, now these are only cautions, they're not something that's a complete contraindication, but it is something that you need to try and establish. And that can then help you determine which antihistamine to recommend. There's some GI interactions, GI reactions that can include the loss of appetite, nausea and vomiting, but again, these are really very rare. And there's also some caution with renal failure and certain fruit juices. So azelastine hydrochloride is the antihistamine that we use in the nose sprays, and it's available on its own in Rhinolast, which is available and prescribable for children over 6 years. And then there's Optilast, which can be used twice daily, up to 4 times per day. And again, these are just things that are recommended. So we're going to move on now to the leukotriene receptor antagonist. Now, this is an add-on therapy when an antihistamine and a corticosteroid are not holding the symptoms. we sometimes use this as an add-on when the patients do qualify for immunotherapy and they've still got another season to go before we can start immunotherapy. So we sometimes suggest that we try Montelukast. Now, we have to counsel our patients really carefully, of course, when we're prescribing any drugs, but certainly with this one, I really am sure that we go through absolutely all the potential side effects, because it depends on the patient's phenotype, whether a leukotriene receptor antagonist is going to work or not. But also, there are some quite noticeable side effects that are more common than other medications that we would prescribe for rhinitis. So it can cause sleep disturbances, vivid dreams, quite severe headaches. So whenever I put a patient on Montelukast, I will say, okay, if sleep suddenly starts becoming disturbed, the child starts waking up, having night terrors, or there's mood changes, and the patient's becoming suddenly quite down, or it just doesn't work, it has to be stopped. Whereas other drugs, you kind of go, okay, well, let's just see how things go, and but these are really specific side effects. If the patient gets any of those, then we literally have to stop the medication. So basically what the leukotriene does is block the leukotriene receptor antagonist blocks the leukotriene, which is one of the chemicals that's released when the mast cell and basophil are triggered by the allergic process. And leukotrienes really sort of help all the inflammation and mucus come into the airways. So by stopping that leukotriene, you're therefore decreasing inflammation and the mucus. So if it works really well. It's licensed in children over 6 months. Often we use it as pulse therapy for viral-induced wheeze, but again, it's an add-on therapy for allergic rhinitis. I talked about some of these interactions already, so I'll slip past that one. So going now onto intranasal corticosteroids. So we know that corticosteroids are anti-inflammatory. Their action is via the gene regulation of immune cells, and it helps to inhibit the production of the cytokines, the leukotrienes, these chemicals that are all released in the allergic process for being recruited into the nose. These are local medications that help to reduce all this just locally rather than systemically. It helps to reduce bronchial inflammation, edema, and mucus secretion. Here's the wide range of medications that are available. So fluticasone is probably one of our most prescribed antihistamines, nasal sprays, and as is Nasonex, but pretty much Avamys is the best tolerated really for as far as the children are concerned, just because it's more of a mist than a gloop. And also the dispenser on it is much shorter, so it's easier to get into smaller noses. We don't prescribe Becanase because it has a higher bioavailability, so that's one that we would recommend to switch patients off if you have the opportunity to. We often use Dimestic. It's licensed in children over 12. We often use it in children who are younger, off license, because it's got two of the medications in that are both prescribed to children who are much younger. So it's really just about trying to get the best possible nasal spray in. And again, it's much better to have a nasal spray than two. You're more likely to have patients that adhere to one spray rather than two. We do have other options as well for the nasal sprays, but really the Avamys, Nasonex, and Dymista are the three that we prescribe the most. Decongestants are not part of any rhinitis guideline, and that's because if you use them for a prolonged period of time, it can lead to rhinitis medicamentosa. So we only use these in the very short term, and it's often not part of our pathways. Looking at our ocular symptom control, it's again avoidance, cold compresses, eye washes, just trying to go down the non-pharmacological route. But we can use mast cell stabilizers, so sodium chromoglycate, that's just available over the counter. And then the main one that we're prescribing really is olopatadine, which is epistastine, which is the local antihistamine, and it's got a mast cell stabilizer in it as well. When we start needing to go down the topical corticosteroid route, we should be referring onto ophthalmology. So you get, with the mast cell stabilizers in the eye, it's really just symptom relief. It doesn't offer any prevention of that, of the symptoms occurring in the first place. It's literally just symptom relief. So the patients that come to our clinic are often already on. I don't know what's happening to my slides, they're jumping all over the place, are often already on an antihistamine, a corticosteroid nasal spray with or without Montelukast, and most likely on some sort of oral eye drop already. By the time they get to our severe allergic rhinitis clinic, they have had testing done already. We've already know exactly what kind of aeroallergen we're dealing with, and they have a huge impact on the quality of life. And with all those things, they meet the criteria for going on immunotherapy. So they have to have these symptoms that are strongly suggestive or confirmed as allergic rhinitis, but they don't always have to have ocular involvement. It can just be nose and sneezing, but it usually has some sort of eye impact as well. We have to have positive IgE sensitization, and we need to have moderate to severe symptoms that interfere with usual daily activities. But we also have to think about whether patients are really taking their medication or not. And I think increasingly over the last few years, we've actually done a prescription request from the GP to see about how much these patients are actually requesting and picking up from the pharmacy. So again, it's only really just about trying to see, is that patient actually requesting that medication, rather than you can't actually prove they're taking it, and they might just be hoarding it at home, but at least you can see that they're actively trying to get the medication from their GP. So thinking about the role of the pharmacist, you're often the first point of contact, and I think it's really important just to have an understanding of what we do to treat each type of symptom. If a patient's just got sneezing, they've just got itching, they just feel generally like their eyes are watery, then we would recommend the antihistamine. If there's any nasal involvement at all, we would add in a corticosteroid nasal spray. So it's about thinking about the symptoms. Certainly, you usually need to have both. It's quite rare that you just sneeze and you don't have any nasal congestion. So we would always really recommend an over-the-counter first-line long-acting antihistamine, such as cetirizine or loratadine. Then you could add in sodium chromoglycate eye drops, and then an over-the-counter steroid nasal spray. But do avoid the Becanase, beclomethasone group, again, because of that high bioavailability. So we can offer some non-pharmacological treatments, such as nasal douching. So there's the NeilMed nasal douche. There's also videos on YouTube about how to do these nasal douching. They can work really well for symptom relief, again, rather than actually treating the symptoms. It's about knowing the allergen season. So download that Allergy UK calendar, or you can have an app which helps to alert you when certain pollens are particularly high, and then think about the impact of that rhinitis on somebody's asthma. So if they've got asthma and they're coming to you with all these other symptoms, then we need to think about what's going on with their asthma, and is their asthma well controlled, and should you be recommending that patient going back to the GP for an asthma review. They might not be on the right kind of treatment for that. So it's thinking about their whole airway rather than just their nose. So the medication advice you can give, you can advise on the dosage. You can explain how to use the nasal spray correctly. You can advise on how to administer eye drops. And we always say, if you lie down on a bed or a sofa, you have the eye closed, you put the drop into the corner of the eye for each eye, and then you open the eyes and then rock your head from side to side. It actually really helps with the eye drops being administered rather than coming at you with a bottle. If the patient knows their trigger, advise on starting ahead of the peak season. So if you know they're a birch pollen allergic patient, then we can advise them to start at the middle of February rather than leaving it through into March, because we know the birch pollen season starts usually around the end of February to the middle of March. We can advise to consult the GP if any of the over-the-counter treatments are not effective. You can think about prepayment prescription advice, because we know these drugs are actually very expensive. If you're needing 2 or 3 prescriptions a month, you might as well get a prepayment prescription. And then you can refer your patients to the Allergy UK website for more information and support. You can show them how to use a nasal spray, and that's actually really important as well, because most people just put the spray straight up their nose and sniff most of it back. But actually it needs to go to the side of the nose, so it goes out in an angle, a 45-degree angle that goes out towards the top of the ear, and you should have your head down when you're doing the nasal sprays rather than the head back. So it's learning about how to use a nasal spray properly, and it's amazing how many people don't know how to use their nasal spray properly. And of course, drugs are not going to be effective if they're not being administered in the right way. And again, thinking about adherence, we know some recent data came out that had a staggering 25% of all asthma and allergy patients don't even collect their prescriptions from the pharmacy in the first place. So then if you think about the patients that do, the 75% that do, are they taking their medicines properly? Are they taking them every day? Are they taking them how we're recommending they take them? So adherence is a big subject. It's a whole lecture all on its own, but it's just something to think about. It's, most people, if they're going to go to the GP and say that they're feeling rubbish and get a prescription, are going to take it on some level, but may not take it all the time. And they're the non-intentional non-adherers. And then there's some people that say, well, I'm just not taking that. I don't believe that I need that. I'm not having, especially the steroid phobic population. So think about the non-adherence and whether those patients are just coming back to you with ongoing symptoms and whether they're actually taking their medication at all. So think about that. It's certainly one of the things that when we're working our patients up for immunotherapy, we're really clear you have to be taking these medications every day. And if we're in any doubt, like I say, we do a prescription request from the GP with the patient's consent, of course. But it's quite interesting, some of the results that we've had back, where we've had like two nasal spray inhalers, for example, in an entire season. So it's quite interesting what you'll get back off that. So just to summarise, allergy to airborne antigens is extremely common and triggers both rhinitis and asthma. Allergen avoidance can be effective, but it's really hard to achieve, especially when it's the pollen and house dust mite. Pharmacists do play an important role in informing patients about their medication, how to take their nasal sprays properly, advising patients on what to do if their medication doesn't respond or doesn't have the response that they're hoping for. It's knowledge of what's available over the counter as the first line, and then knowing when to go back to the GP if those medications are not working. And then it's really about going on from there. It's about coming into a tertiary centre for consideration for immunotherapy. If patients are having a daily antihistamine, a corticosteroid with or without Montelukast eye drops, they're taking their medication regularly and they're still having a poor quality of life, then they certainly meet the criteria for immunotherapy. And we do immunotherapy for house dust mite, grass pollen, tree pollen, and in very small amount of our patients also have it for dogs, cats, horses. Like one of our patients, for example, lives near a farm, and it's really impossible for her to avoid horses. So she's on horse immunotherapy and she has anaphylaxis every time she's near a horse. So she definitely meets the criteria for animal immunotherapy. So we have a few patients like that who are on animal dander immunotherapy, but the vast majority are on grass, tree and house dust mite. I'd be very happy to take any questions. And I do apologise for my beginning there with the technical issues.
Thank you so much, Rebecca. That was really interesting, and it really brought to life what a significant and important role pharmacists have to play in helping patients to manage symptoms of allergic rhinitis, from that avoidance to their specialist knowledge on medicines and treatments, and the patient education and support is really important. I have a couple of questions for you. The first is, and this is particularly pertinent to your expertise as a paediatric nurse, what age or around what age are children able to use a nasal spray? We've talked about the age that products are licensed, but I'm thinking about their ability to, that hand-to-eye coordination, of being able to use it. In your experience, what age groups?
It's a really good question, and that's really based on the individual, because we have some 6-year-olds who are just completely great. They take their, we can start immunotherapy as early as 6, and they're even able to take immunotherapy without their parents. They've been told what to do and they're doing it. They can, so it really is a very personal thing. But I'd say by and large, by the time a patient's going on between above 8, I would say that they're able to understand that the direction at which they need to put the nasal spray in. It's about blowing the nose first, looking down at your shoes, and it's one spray either side into each nostril in a diagonal. Most kids can kind of grasp that by that kind of age. But, obviously you have to just base that on the individual, especially if the child's got learning difficulties, any kind of sort of problems with eye-hand coordination as well, like you say. So, yeah, I'd say usually about age 8.
That's great. Thank you for that. And we get lots of parental anxiety around the use of steroids, particularly topical steroids in eczema. What reassurance would you give to patients or parents with regards to prescriptions for intranasal steroids in children with regards to safety?
Yeah, so like I mentioned, the one that we usually use is the fluticasone or mometasone, because they have a low bioavailability, and we reassure those parents that as long as they're using the nasal spray properly, it really is only absorbed locally and not systemically. And it's actually thinking then about the broader picture. So if they've got nasal congestion that's not treated, they don't sleep, they don't concentrate, they're irritable, they're not able to breathe so well, they're probably not performing so well playing sports. That has an impact on the development and treatment of asthma. So without scaremongering them, it's about just trying to say, just by giving this nasal spray, you're just treating the local area. It's hardly any is being absorbed at all, as long as you're taking it properly. And actually the benefits outweigh the risks. So as long as it's administered properly, it's actually going to be much better for that child to be able to breathe. And then you don't want to start saying, well, if you don't do this, they're going to get asthma. But the evidence is pretty much, if you leave allergic rhinitis and you're sensitized to that particular aeroallergen, and you're going to go on and it's going to potentially affect lower parts of the airway. So it's about having a wider, longer term approach to this. And also, if you say to them, if they're saying you don't want to use it as a bargaining tool, but you say, if you use these nasal sprays and things don't work and it's still ineffective, then there is the potential of immunotherapy, but you have to be on these nasal sprays before we would consider that. So it's also about giving them some reason to try something, because there is an alternative at the end. So it's really about kind of giving them the broader picture and reassuring them that the steroids that we're using only react, are only responsive in that small area.
Great, thanks, Rebecca. I really appreciate that. Thank you for your presentation and for taking those questions. We're going to go to a short break now, and we'll be returning at 2:45. Where we'll be having a presentation on atopic dermatitis and chronic spontaneous urticaria. So please enjoy your break, and we'll be back online with you at 2:45. Thank you. Good afternoon and welcome back. We hope that you're joining us refreshed, and it's my pleasure to introduce our next guest speaker. Her name is Julie Van Olsenman, and she's going to be talking this afternoon on atopic dermatitis and chronic spontaneous urticaria. Welcome, Julie.
Thank you very much, Holly, for your kind introduction, and good afternoon, everyone. I'm delighted to be talking to a group of pharmacists who I feel play a very important role in dermatology, stroke allergy. So this presentation will be a run through looking at atopic dermatitis, recognition management, alongside chronic spontaneous urticaria, which can also occur with atopic dermatitis, but also can be a separate condition itself. So we'll try and sort of get you to understand the difference between the two and when they come together and when they're separate. So first of all, I'm delighted to say that there are some learning outcomes, and hopefully by the end of this session, you'll improve your evidence base on atopic dermatitis management according to the guidelines, which I'm going to share with you, NICE and PCDS. I hope you'll understand more about how to maintain a healthy skin barrier to prevent allergy sensitization, which is a really important step in managing atopic dermatitis. But then I hope you'll gain knowledge about chronic spontaneous urticaria and the relationship with atopic dermatitis. Finally, I always like to think that my talks will give you a little bit more clinical confidence because you're seeing the patients with eczema and chronic spontaneous urticaria, and you're advising them and supporting them. So I hope you'll have a few tips by the end of the presentation to help you with this. Just to acknowledge that my images come from DermNet New Zealand and the Primary Care Dermatology Society. The websites are there, both fantastic websites, a wealth of information and advice and support for healthcare professionals managing patients with dermatology conditions. So I always think it's good to start at the beginning with a definition, and we hear the word atopic dermatitis, I think now, perhaps a little bit more than eczema. And in a way, that's just a trend because the word eczema and dermatitis are interchangeable. I suppose generally in my time, we've always used atopic eczema, and it's been perhaps a UK definition, but now atopic dermatitis is being seen as a definition as well, really due through the wealth of research and the fact in the States and in Europe, it's tend to refer to as atopic dermatitis, but they are exactly the same. So atopy means Greek for out of place, and atopic is the inherited tendency to develop eczema, asthma, or rhinitis. This is really important. So when somebody has atopic dermatitis, they usually have a genetic predisposition. The precise inheritance isn't so well known, but we do know there's very strong genetics. There's also genetics connected to the skin barrier, which I'll talk about in a minute. But eczema itself is a very individual condition. It's modified by environmental factors. So what will trigger one person may not trigger another. There may be universal triggers. And eczema tends to be preceded by the development of asthma and rhinitis. We call this the atopic march, and it now also defines the compromised skin barrier as the first stage. So let's look at this atopic march in diagrammatic form. We see that atopic dermatitis is generally the first condition to develop, but alongside food allergy for some children as well. So again, that really is quite a useful graph because obviously not every child with eczema has a food allergy, but food allergy is connected to eczema. More of that later. Asthma tends to be next in the march with allergic rhinitis. So asthma really peaks later childhood, sort of 6 to 11 teenage years, and allergic rhinitis or hay fever has a steady rise, and you can see how the atopic march is there throughout life. So a big question from parents is, what is the cause of my child's eczema or atopic dermatitis? Or even adults are still seeking that cause. So it's very important to tell people, and I'm not going through this diagram in detail because I haven't really got time, but it is really quite complex. There's a very complex immune process. So atopic dermatitis is a disease of immunology, the immune system. Alongside that, with all the immune processes, which are basically what is triggering and flaring the skin and causing the inflammation and the waveform pattern of eczema. You've also got increased microbial colonization. We're learning a lot more about the microbiome of the skin. So people with eczema have a lot more Staph aureus in their skin. And also a really important part is this reduced skin barrier. So your skin barrier normally is quite resilient, but when you have eczema, and certainly what we do know from fairly recent research about 20 years ago, is the filaggrin mutation, which is a genetic mutation, is there in 50% of people with atopic dermatitis. It's linked with early onset, it's linked with allergies, high IgE levels, and adult eczema. And now we have an explanation why some children grow out of eczema and some children don't. And these people with the filaggrin mutation, they have a defective skin barrier for life. Atopic tendency also means that we know this inheritance. So if one parent has an atopic condition, it may be eczema, asthma, or hay fever, there's a 25% chance, or a 1 in 4 chance that that child will develop 1, 2, or even 3 of the atopic conditions. We don't necessarily know which condition, so the inheritance is quite confusing. So for instance, a mother with hay fever may have a child with severe eczema. So there is an inheritance there. If both parents have the atopic gene and have an atopic condition, there's a 1 in 2 chance. So I talked about the skin barrier, and one thing we do know for sure is that allergen sensitization occurs much more readily through an impaired skin barrier. And this is why people with atopic dermatitis are much more prone to allergy. So in normal skin, we've got a normal barrier that's impenetrable to irritants and allergens, and it prevents water loss from the body because there is a high level of natural moisturizing factors within the normal skin, attracting water and leading to this very resilient barrier. Also, the lipid lamellae, including ceramides, keeps high levels of water and keeps that firm barrier. When you have dry skin, eczema, dermatitis, and if you have the filaggrin gene deficit, this is for life, you have a skin barrier that looks much more like a broken down brick wall. So the corneocytes shrink and shrivel and cause cracks between them. The natural moisturizing factor levels are reduced significantly by about 80%, and the lipid lamellae starts to crack around the shriveled corneocyte cells. So you can clearly see that dry stone wall analogy where the skin has become very penetrable to allergens and irritants, and water is being constantly lost. So actually the constant repair of the skin barrier is really one of the most important lines of management in eczema. And so this is another graph that's very, very useful because we look at when the skin barrier isn't optimal. And the skin barrier isn't optimal when someone has atopic dermatitis, and atopic dermatitis can last throughout life. But what we do know is that the stratum corneum is still developing in the first year of life. It's 30% the resilience of an adult in the first year of life, and only becomes the adult resilience, and this is in people without eczema, at age 1. The skin barrier throughout life is very resilient until you get to around about 50, and then your skin barrier starts with age and physiological degeneration to fail. So by 60, nobody has a resilient skin barrier. And that's why we also see a lot of eczemas or dermatitis related to age, and also atopic dermatitis, if it has been quieter in the adult years, can often come back for older people. So people always ask, and this presentation, by the way, is based on questions. I think that's been the theme of the day. Do children actually grow out of atopic dermatitis? So I think now you know that 50% will never grow out, but a lot of children will remit or become a bit better during adolescence. But then eczema can come back in adulthood as a chronic phase, And also patients with a history of atopic eczema are more susceptible to irritant contact dermatitis. And sometimes people even call that sensitive skin. Sensitive skin obviously has a spectrum from skin that's simply sensitive to people who have contact dermatitis and have many allergies related to topical applications on their skin. And of course, going back to the beginning, the common time for atopic eczema to start is between 3 and 6 months. So that's quite important because there's quite a lot going on in terms of child development and also weaning at 6 months. And as I said, eczema can return or occur for the first time in older people. So just a few pictures. Always nice to see pictures in dermatology presentations. You've got atopic dermatitis. So you've got two little twins here, and often in babies, you see the eczema is worse in the facial areas and a little bit more generalized on the body. Before atopic dermatitis develops, babies often have cradle cap, which is actually a physiological condition. It's basically an overproduction of sebum from the sebaceous glands. If a baby has more severe seborrheic dermatitis and they have a family history of atopy, this can be a marker for them developing atopic eczema. And you know for sure when seborrheic dermatitis has turned into atopic dermatitis when the baby starts rubbing, itching and scratching, because seborrheic dermatitis is never itchy and atopic eczema is always itchy. In childhood, you generally see a classic pattern of eczema in the flexural areas, but remember this can be different in different skin types, and there can be some very difficult patterns of eczema. This little girl has severe eczema in a discoid form, and some parts of the body can be exceptionally difficult to manage, such as the eyelids, and the eyelids often are stimulated by allergy to pollen or airborne allergy. So in adults, atopic dermatitis can have different patterns. Often the eczema does return to the face, and in adults, atopic eczema can be absolutely devastating as a chronic, ongoing, incessant condition that can affect relationships and life quite phenomenally. You can get discoid eczema, these round areas, and of course if you have varicose veins, you can get varicose eczema, which if not treated could even lead to ulceration. This is contact dermatitis, so this is a contact allergy, and you can often get a very vivid sort of blistered reaction. And seborrheic dermatitis in adults is different. It's a susceptibility to the yeasts called Melisma furfur, so you need anti-yeast treatment here. In older people, steatotic eczema is really the degeneration of the skin barrier due to aging, which actually can form a very nasty sort of constitutional type eczema. So that gives you a little bit of a run through of different types of eczema and how they relate to atopic eczema. I always think it's very important to talk about how atopic eczema presents in darker skin types, because we really need to build up this knowledge and incorporate it whenever we speak. It's really, really important. This little one has really severe eczema. You can see the eczema's on the front rather than behind the knee. This is called the reverse flexural pattern. And indeed, there are dry, scaly areas more prominent on the front of the knee and on the front of the foot. You definitely see the front of the foot in children with white skin because generally they can rub their little feet together. But the actual flexural pattern of the eczema on the knee can often be mistaken for other things. But this is eczema, particularly if it's itchy. So it's very important to diagnose eczema. In darker skin, there's additional problems of hypo and hyperpigmentation. So when eczema is inflamed, eczema will be hyperpigmented. So there will be darker patches of skin. This boy again has very severe eczema, so you can actually see pink patches. But in people with less severe eczema, the eczema would be darker hyperpigmented patches. When eczema is treated with steroids, often this pigmentation can change to be hypopigmented. And this is confusing because a lot of parents worry this is a side effect of steroids. No, this is actually an effect of eczema responding to treatment, and then gradually skin pigmentation will return. So if you go to the mildest form of eczema, this is where you see it. So again, you see hypopigmented patches in a child with something called pityriasis alba, which again is a hyperpigmentary change on eczematous skin. Very mild eczema, only needs emollients, but again, you can see pigment has been disrupted. So there are lots of symptoms, and why does eczema relapse and remit? Well, if you look at the symptoms, you get dry skin, really, which is the main symptom, which can become scaly, very itchy skin. Itchy skin becomes red because it's inflamed. Then it can become weepy because it cracks open, and weepiness can often mean that it's sore or crusty, which means it's infected. And then you start the whole cycle again with dry skin. So I rather like to describe it like a waveform pattern. And this is really important to managing eczema and the points where you treat it. So you've got your classical acute, subacute, and chronic. So when you have an eczema flare, you've got an acute flare of eczema with the inflamed skin. So you've got a very stormy sea, and you're trying to calm that sea. You calm the sea down with the management, and then you have a quiet period where eczema is perhaps just dry, perhaps, you know, more chronic, and you're using your moisturizers again through this phase. And then you have another little blip, and you may have a subacute flare. So the eczema isn't quite as bad as there, but it's another flare. So you've always got to be aware of treating eczema on the crest of the wave to bring it down to a quiet sea. And that's just an analogy which I think is really helpful. It's really helpful for parents as well. And I say, if you're not controlling eczema, you've got this continual stormy sea. But even when eczema is well controlled, you're still going to get a freak wave, i.e. you still might get a blip. So what triggers atopic dermatitis? Well, there are lots of irritants and allergens, or allergies, I should say. So basically, we know that heat, soap, even stress, and even the weather is not necessarily an allergy, but it's something that will irritate eczema. But we know that if you tested every single person with eczema, they would show high IgE levels to two things which are hard to get rid of. Inside, the house dust mite, which lives in all our carpets and furnishings, and outside, pollen, and tree pollen and grass pollen. So this is why when parents say to you, I want allergy tests to know what the cause is, I think we have to go back to the third slide. Eczema is complicated. There's no single cause. Allergy testing, of course, is indicated for a number of children with atopic eczema, and eczema is difficult to manage. But at the start, we have to look at the general irritants and allergens. So, of course, infection can drive eczema. We'll talk about food in a minute. And some children are allergic to pets, furry and feathered pets. I get very interested how people really, really stress about washing powders. And I actually say washing powders were a problem when we had machines or we hand washed and we couldn't get rid of the soap in the clothes. The biggest problem now is what we leave on the clothes. So fabric conditioner to make the clothes softer often is irritant. And of course, if you then hang your washing on the line after washing it and it's the spring, it can get saturated with pollen, and that's actually what's causing the irritation. Most machines have a double rinse cycle now, so actually washing powder I think is less relevant, although some people say a biologic is better. There certainly are food allergies associated with atopic dermatitis. It's not exclusive because you can get these food allergies without eczema and vice versa. So these are the 8 main groups. So dairy, particularly cow's milk protein, eggs, wheat, fish, soy, tree nuts, peanuts, and shellfish. And of course, shellfish and peanuts and tree nuts will be, and some fish will be around the allergies for life, whereas eggs, wheat, and dairy, people can actually, acclimatize to those allergies, particularly cow's milk protein allergy. So when we look at managing food allergy and atopic dermatitis, we know that early onset eczema increases the risk of cow's milk protein allergy, but atopic eczema and cow's milk protein allergy can coexist. So the general rule of eczema is that we would consider a food allergy for children under 2 who've reacted with immediate symptoms, or a child whose eczema just is not controlled by the optimal management. So if cow's milk protein allergy is suspected, and Allergy UK has the most fantastic fact sheet on cow's milk protein allergy, you've probably heard about that today, we start a trial of hydrolyzed protein formulae. It's really important not to use diets based on other unmodified proteins of animal milk, because if you're allergic to cow's milk, you're going to be allergic to sheep, goat's milk, and indeed even soya as well. So we need to be really quite certain of that. So the itch, scratch cycle and damage cycle is really, really significant in eczema. So you've heard about the dry skin, which drives the inflammation, which starts the itching. The itching leads to the scratch, which can lead to damage, which can lead to more eczema and a feedback system. So what we've got to do is we've got to try and break this circle at these various points. So to stop dry skin, and remember dry skin is always itchy skin, you really need to look at your emollients, where itch is treated with complete emollient therapy. So that's emollients for washing and moisturizing to try and prevent dry skin, to prevent the itch. If itch leads to scratching and there's lots of inflammation, as in the acute eczema, you need to then add in your first-line topical steroids or other treatments as necessary, depending on severity. The one treatment that doesn't treat itch in eczema are antihistamines. So there's categorically no role for non-sedating antihistamines. So please prescribe more emollient instead. And sedating antihistamines are worth trying as a trial, maybe to help restore sleep. We normally, because basically, as I said before, eczema is complicated and there's not a definite histamine pathway. Now, when I talk about urticaria, this is totally different, because in urticaria, antihistamines are the first-line treatment. So we talk quite a lot about diagnosis and looking at the visible flexural eczema, looking at history of dermatitis, dry skin, and family history. So that's the diagnostic criteria. It's not that hard to diagnose, and if there's doubt, it should be referred. So let's move on to urticaria and describe what urticaria is, and then we'll look at the treatment pathways for both eczema and urticaria. So urticaria is describing a disease that may be present with short-lived itchy wheals, angioedema, or both. And it may be induced or it may be spontaneous. So it's a strange condition where the skin literally reacts, and sometimes it reacts to something we know, and sometimes it's spontaneous. And basically the key symptom is the skin erupting into these temporary wheals, sometimes hives or even nettle rash is the lay term. And then you can also get an angioedema, where you get swelling of the eyes, the lips, or sometimes even the thorax. So that can be quite dangerous. Sometimes spontaneous, and sometimes that's called ordinary or idiopathic for no cause. It just happens. And other times it can be inducible because of physical means, for example, exercise, due to heat, due to contact allergy as well. So there's a whole range of reasons why urticaria results. If it's inducible, it's much easier because you can actually find a cause. So a wheal is the main symptom. It's a transient, well-demarcated pink patch of skin that becomes very swollen. It leaves edema in the skin, and generally it then fades away, often within hours, leaving no mark at all. But wheals are very itchy, and they're associated with a flare of the surrounding skin. So you see some picture of wheals there. This is a very good picture of urticaria. This is a classic wheal pattern. So it's likely by the evening or by the next day, this horrible, itchy, swollen skin will completely resolve. And that leads to a problem with history and diagnosis, because often there's no skin symptoms. It's important to talk about angioedema because it's a term for deep swelling of the dermis, subcutaneous or submucosal tissue. So you can see the mucosal tissue with the little lips and the subcutaneous with the dermal. So what happens is often a sensation of itching and tingling, and then it's often a part of urticaria, so part of something that's been induced by urticaria, but it's a deeper induction because you get angioedema. It's painful rather than itchy and can occur anywhere on the mouth or skin, and often the symptoms of angioedema, the swelling, last a lot longer. And it can present without wheals, particularly in spontaneous urticaria, and it can sometimes be brachykinin mediated or hereditary. The angioedema can lead to anaphylaxis, so that's really, really important to be aware and know that that's a sudden, severe, life-threatening reaction, often involving the skin due to mast cell mediator release. And that anaphylaxis can happen if there's an allergic reaction. A good example is latex. Putting a hand on a latex balloon can suddenly cause a severe allergic reaction with angioedema, or it can be non-allergic. So it's very important to be aware of the signs and be aware of what you need to put in place in terms of emergency response. So when you look at the acute and you look at chronic spontaneous urticaria, it's quite important to look at the difference between the two. So acute is more acute, inflamed wheals that suddenly appear 30 minutes to 4 hours, and new lesions can come and go over a period of time, and they affect any body site. Now, acute urticaria is much more likely to be associated with angioedema, less commonly with anaphylaxis, but you can see this with food allergy, drugs, and stings and bites. Whereas chronic spontaneous urticaria, the symptoms can actually last for 6 weeks or more. Wheals can even start to develop into blisters, and rubbing the skin causes the skin to bruise. So 50% of people with chronic spontaneous urticaria may experience angioedema, and 10% can even have angioedema without wheals. And as I say, there's sometimes not a specific cause, but often aggravating factors are, as we've said before, physical infections, drugs, diet, even premenstrual and stress. So it's just worth knowing a little bit of a difference between how they both present. So when we're looking at assessment, we'll look at atopic dermatitis first, and then we'll look at an urticarial assessment as well, so you know what we're looking for before we move on to management. So you're looking at diagnostic features, extent of eczema, the extent of itch or how itchy it is, because itch really is the cardinal symptom of eczema, and you're looking for any evidence of deterioration such as infection. And for all children, they should have their growth and development checked with height and weight. You're asking about individual triggers, and then you're discussing more universal triggers for eczema as well, so people know what to avoid and how to adapt their lives. But very important to assess current and previous treatment in terms of bathing, showering, moisturizing, and then in terms of flare management, what they're using, how much they use with topical steroids, antihistamines, or other treatments. The impact of eczema is really important, and it's important to look at the psychological, particularly lack of sleep, days off schoolwork, and also look at physical symptoms. So in my practice, and I should have said I work in an NHS clinic in South Birmingham, and I work virtually. I've got very clear on doing a POEM assessment for anyone with eczema atopic dermatitis, because the POEM is very good, and you can download it from the Nottingham University website, because it really gives you a very good view of physical symptoms. And once you've got a marker of physical symptoms, for instance, if you have somebody with moderate eczema, you would then follow the NICE guidance and treat them on the moderate pathway, and then you'd assess them in a couple of weeks. So very, very useful, and gives patients confidence really to progression with management as well. It's important to be holistic with your assessment and look at quality of life. So the DVLQ is very, very useful, because you can ask these 10 questions which really look at how their skin condition affects life. And there's a cartoon version for children as well. And again, with treatment and pathways put in place, this can really improve as well. And again, can really help increase patients' confidence and well-being. The history and assessment for chronic spontaneous urticaria is slightly different, because, as I said, you often are making a diagnosis with no skin lesions at all. So you have to ask about the attacks of CSU and get a thorough history in terms of the duration, the physical symptoms, the presentation of wheal and itch severity, aggravating factors, and family history. There's also a very good impact on quality of life. You can look at DLQI again, or the chronic urticaria QOL score, and any previous diagnostics and tests that have proved urticaria. Test tends to be provocation, so provoking urticaria by the trigger that's thought to be the provoker, and then looking at threshold tests. How long could somebody bear, for instance, cold or hot before it induces urticaria? Dermabrasion is really important because that's very common in chronic spontaneous urticaria, and literally it's an exaggerated wheal that occurs within minutes of the skin being scratched or even stroked. So if you stroke somebody with urticaria and you suddenly see a wheal forming, that's a very good indication to diagnose chronic spontaneous urticaria as well. So that's a very graphical picture of dermographism, which is what we call it. So we now move on to treatment in the last 10 minutes of the presentation. So we're looking at the guidelines. We're looking at the PCDS, Primary Care Dermatology Guidelines, and their steps. And we'll also have a little look at NICE as well. So the PCDS eczema treatment pathway, they have one for adults and one for children, and they focus on an ABC pathway. So you're avoiding triggers, you're using bland emollients as part of your daily routine, and you're controlling inflammation, which may be with steroids and second line with calcineurin inhibitors. NICE have a very similar step pattern. Again, we look at stepped approaches for eczema, a step up or step down of treatment, and matching the severity of eczema with the age of the child and the area of the body to know how to treat. And again, you've got calcineurin inhibitors that come in with steroids as well. So calcineurin inhibitors were recommended as second line or to be used as a treatment alongside eczema when the NICE treatment pathway was devised in 2007. But I think they're the treatments least used, but they're very, very useful, particularly for maintenance. So step one is general measures. And as I say, I've just mentioned the consultations I do, which are virtually because of COVID-19, but we also would advise adults on prepayment prescription, and at every stage we'd ensure compliance and copious emollient use. We'd also provide written action plans, and there are some very good examples of written action plans for eczema with the Harmonising Eczema Measure project and the written eczema management plan from the University of Bristol. So initial management for patients presenting with a flare-up, so when eczema is flared and it's acute, it's much better to hard hit using potent treatment for a few days and then use your less potent treatment for longer periods of time. So what we'd recommend is, and first point is, steroids only need to be used once a day. Because that was some very good research in 2010, which actually said that once a day was the same as twice a day. So even with a small child, 3-4, if they have difficult eczema, you could step right up to a potent steroid once a night for 7 nights, then every other night. A slightly younger child, you might use a moderate or even a mild, and an adult, depending on when the eczema is, you'd use stronger steroids for the hands and feet, for instance. But you look at this 2-week treatment burst. You may add in sedating antihistamines if sleep is a problem, and obviously swab the skin if it's not settling, because this might indicate infection. And then for long-term management, you're helping the patient to recognise their flares, so they continue with their emollients. But if their skin flares up, and think of my waveform analogy, they need to then hit hard again for that 2-week burst. And then the idea is after 2 weeks, they stop their steroids and they moisturise only. You can also use bandages for occlusion, and in terms of dressings, that's more therapeutic clothing to help prevent scratch itch as well. So helping patient with emollient choice is a very wide area. And I think really we've got to not really think about the names of the emollients, but think about the patient and think about what their emollient needs to do. It needs to treat dry skin, it needs to repair the skin barrier and relieve itch, but it needs to have a formulation that's effective for that patient. So a patient with drier skin might be better with an ointment or gel. A baby with less dry skin who gets very hot, they might be better with a cream. If it's a sort of mild eczema, lotion might be fine. If it's a more severe eczema, you might need to maybe use an ointment at night to cream in the day. But I think it's very important that emollients are cosmetically acceptable, because if the patients like them, they'll actually use them. So putting any brand names aside, but I can give you some examples. You've basically got 3 types of emollient and how they act. So you've got a simple occlusion. So we think back to the beginning where we've got this broken down barrier. So the emollients occlude, they trap water under the emollient, and they encourage the corneocytes to swell with water and repair. Unfortunately, this will only last quite a short time. So for a baby having a nappy change, excellent. But for somebody who's going to school or college, to put on emollient every 2 hours will be arduous. If patients have very dry skin, again, babies can use this in the day. Adults, a bit difficult when getting dressed. You can use a heavy emollient, an ointment, where you actually, again, the same sort of occlusive effect, but because it's thicker, it's going to last a lot longer. So remember we talked about the lack of natural moisturising factors in the eczematous skin barrier for the 50% have the filaggrin deficit. This is where the humectant occlusives can be so useful. So they're emollients that not only occlude, but they also add NMFs into the skin. They're more cosmetically acceptable, and they probably last 6 hours rather than 2 hours. So again, for someone at school or college or work, that's a very useful formulation. So you're trying to give patients choice. You're also trying to work out how they're putting on their emollient, and you're asking them how they apply, because a rub will always stimulate an itch. So we talk about the dot, stroke, smooth, and we mind the gap, having a gap between emollients and steroids. My preference when eczema is acute is to have a nice emollient bath or shower. You can use the same emollient for washing as moisturising. Then pat dry, then apply the steroid on the inflamed areas, wait 30 minutes, and then apply another layer of moisturiser. The only exception to that 30-minute rule is tacrolimus, where you're meant to leave 2 hours. And it's very important to advise on the safety warning on flammability, because that is a real problem, albeit rare. And it's very important that, you know, children's clothes are changed regularly so they don't get oil soaked, because that's the danger of oil soaked into clothes and being near any kind of flame, which can include smoking candles or open fires. So downward stroking action, and as I say, if you've got a tub, do decant as well. Topical steroids application, again, very important. So there's your sort of ladder. So as I say, we talked about the hard hitting. So you jump up and then you step down rather than step up. You need to be, you need to be respect steroids, but not be overcautious, because a lot of patients I speak to, and I work on the Eczema Society helpline, their eczema is not controlled because they're not using enough, or they've even been scared. So when you're looking at eczema, you measure where the eczema is. So 2 handfuls equates to 1 fingertip, and you'd need to apply that much on just that arm for 1 night, for 7 nights, then every other night. Obviously, we match mild steroids with the face and the eyelids. And if you've got very bad hand or foot eczema, you might need to go straight up to a potent, because the skin is much thicker there. And you're also matching the steroids with age of child as well. So this is, again, really simple. You can see my acute and subacute pictures reappear. So this is when we're talking about getting control. And then if the eczema hasn't quite cleared, you can keep control by using something we call weekend therapy, where you use the same topical steroid for 2 consecutive days, 1 day after another during the week, for up to 8 weeks. And that's quite a good way of maintaining and having more moisturisers on the other 5 days, but trying to get to the point where you're just using moisturisers only. If there's no response to adequate topical treatment, think infection, and don't prescribe antibiotics routinely for untreated eczema. If you've got an obvious crusted yellow sore patch, that will probably be a patch that could perhaps be treated with a topical antibiotic combination. But if there are more over the body, you may need to prescribe a systemic antibiotic. And of course, be aware of very painful skin, blistered skin, small vesicles. This could be a rare viral infection called eczema hepaticum, which comes from the common cold sore. So always think infection, and always be ready to swab or treat infection if need be. So immunomodulators, I said, are fantastic and come along steroids, and I use these for patients' facial eczema and sensitive areas, because I would personally not want to use stronger steroids on the face. So actually moving to an immunomodulator, so tacrolimus is Protopic, pincrolimus is Elidel, perhaps Elidel for children, and tacrolimus for adults, although tacrolimus can be used from 2 years old, and the weaker dose really from 2 to 16, 0.03 and 0.1 for adults. It's just fantastic, even though it stings when you put it on. People often work through that, and most people can tolerate a topical immunomodulator as a maintenance, so you can use that twice a week on 2 divided days, and that can really reduce the severity of difficult facial eczema. So they are advised within the guidelines, and should be considered if there's any possibility of skin atrophy, and around the eyes is the thinnest area of skin. So I think it's really important to, consider these sooner rather than later, and they certainly can be prescribed in primary care. Scalp eczema, you've got to think about removing scale before you treat, and we often do use, lotions or scalp applications. In fact, a lotion's kinder because the alcohol content can sting. And then obviously referring to a specialist is really important if there's any diagnostic doubt or the person has severe eczema and they're eligible or need secondary care treatment. So chronic spontaneous urticaria is managed fairly differently, and I think the graph, which you can read as I talk, is very, very useful. So again, you're trying to avoid aggravating factors. The treatment for chronic spontaneous urticaria is antihistamines, and actually is non-sedating antihistamines. And so if the response is, you start with a standard dose once a day. If response is inadequate, increase to twice a day, and the treatment can be increased further up to 4 times non-sedating antihistamines a day, usually taken as 2 tablets BD, so quite high doses. Higher doses you need to consider other morbidities with fexofenadine and cetrazine, but generally you can build up to that level. And it is safe to take antihistamines for as long as needed. So 10% of patients can still feel tired, even though they're non-sedating, but non-sedating antihistamines are first line. For angioedema, you do have to look at short-lived episodes. You may look at EpiPens for adrenaline for very difficult episodes, and then you'll also look at the acute symptoms. So you've got to be aware of acute symptoms as well, and life-threatening situations. And again, Allergy UK has lots of information on that. Sorry, I'm aware of time. I'm galloping slightly, but this is the summary. So for atopic dermatitis, emollients, steroids, if thinking infection if no response, consider your immunomodulators. Here's some website for referral and for guidance and patient information, and chronic spontaneous urticaria, advice on lifestyle measures, non-sedating oral antihistamines, avoid sedating, manage your acute systems, and look at the websites as well. So there's lots to think about with the 2 conditions, and just to be alerted to when it's atopic dermatitis, when it's chronic spontaneous urticaria. So I've now finished my presentation, so I'll stop the share and I can be available for any questions, which I believe are live.
Thanks, Julie. Thank you so much for that detailed presentation. You had quite the challenge there, covering both atopic dermatitis and chronic spontaneous urticaria, but you did an excellent job. A couple of questions for you. Is there any way of preventing eczema, particularly thinking about parents planning on having another baby who may already have a child that has atopic dermatitis?
Yeah, I think that's a really good question, and I also think it's a question that parents is very much in their mind, particularly if the first baby has atopic dermatitis, and it's a really real concern. I think first of all, if the first baby's had difficult eczema, it doesn't always follow that subsequent children even have eczema, and the atopic gene is complicated. There has been reasonable amount of research on probiotics. The problem is, and we've just had the new NICE guidance out, so it's very useful to quote that, but the NICE guidance is still saying fairly clearly there's no evidence-based way to prevent eczema with any supplementation in pregnancy or any preventative measures you may be able to do in pregnancy. And of course, we would always say, you know, it is best if you can to breastfeed for the 6 months, but again, it's not necessarily, breastfeeding is not necessarily preventative. So I think the jury is slightly out. I think we should keep an eye on the probiotics research coming out, and there might be, I don't know if you've got any more information. I know there was a study at Imperial College, but I think NICE have said it wasn't conclusive enough to certainly recommend probiotics through pregnancy, but that's sort of the area that, you know, could be something to watch, so to speak.
Thanks, Julie. That's great. And one last question. One of the delegates has asked if you've ever heard of the Dr. Aaron eczema treatment regime, and if so, what are your thoughts on this? It's a way of combining topical treatments.
Yes, it's an interesting thing on this, and I think it's a very compelling Facebook page and website, and I believe, you know, there's a lot of passion with this method. Now, the slight issue for people in dermatology is the Dr. Aaron method actually almost goes back to the method that children were treated with in the 60s, 70s, which actually led to side effects with steroids, because what it really is it's mixing everything together. So you're mixing emollients, topical steroids, and also antimicrobial creams in one pot, and then the child is having that smothered on. And nowadays we would like to be much more cautious, and we would much prefer to follow the NICE guidance and the PCS guidance, which talk about using emollients separately for long-term management and then coming in with using topical steroid for flares. And again, the CREAM study in Bristol very clearly said only use antibiotics if there is actively infected eczema. So I know people have had success with it, but I think in dermatology it slightly worries us because we feel it's quite an old-fashioned method, and I don't think, you know, the treatment pathways currently wouldn't see it as having an evidence base. I'm not being harsh on it, but that really is the bottom line, because I think then people get very reliant on always using emollients and steroids and antimicrobials mixed up. But I also, you know, there's a feeling that it's all diluted, but also the other worry is that it's diluted, but then sometimes if you mix emollients with topical steroids without mixing them in a pharmaceutical formulation, which has been researched, you actually then reduce effects of other treatments. So we wouldn't, in the Eczema Society, we wouldn't necessarily recommend it. We would tell people what it is and people have their choice, but we would prefer to follow the treatment pathways from NICE and PCDS who don't recommend it. But that's what it is, in case you're wondering.
Super. Thank you so much, Julie. Much appreciated. So without further ado, I'd like to introduce our final speaker of the afternoon. James Gardner is a children's allergy nurse consultant from the Great North Children's Hospital in Newcastle, and he joins us this afternoon to present a practical session on AAI education. Welcome, James. Thank you.
So, hello everyone, my name is James Gardner. I am the Children's Allergy Nurse Consultant at the RBI in Newcastle, and this session is about adrenaline auto-injectors, anaphylaxis, and we'll go through a case to describe that. So firstly, we're going to define anaphylaxis. And NICE described that as a severe, life-threatening, generalized systemic hypersensitivity reaction, and that's characterized by rapidly developing life-threatening problems, often involving the airway. So we often have patients with breathing difficulties and often feel tight-chested, And that can be associated with some circulatory problems, certainly in adults, where they can become a bit hypertensive and can often feel faint, or indeed lose consciousness. Most cases are associated with some form of skin rash, be that urticaria or erythematous rash, and usually with mucosal change as well, so you may get some angioedema as well. The European Academy of Allergy have a consensus on allergy. It took a long time to get together with all the experts in allergy across Europe, coming up with these symptoms. The reason I show you this is one thing that I liked that was added to this guideline was, as well as all the usual symptoms, there's also gastrointestinal symptoms are involved here. And this is not just a little bit of an upset tummy. Patients with anaphylaxis will often have crampy abdominal pain, be bent over with significant pain, and often associated with significant vomiting or diarrhea as well. So I'm going to present to you a case. Tom is age 6. He was known egg allergic, previous milk allergy, and has multi-system allergic disease involving eczema, asthma, and also hay fever. By accident, he was given a sandwich at school which contained mayonnaise and obviously containing egg. Immediately, he vomited. He developed some swollen lips, a hoarse voice, and feeling of being tight-chested. So initial thoughts here, and what do we think about treatment? So obviously, we think it's anaphylaxis. He meets that definition. He's vomited there. He's got some swollen lips. But then those all-important respiratory symptoms, a hoarse voice, which would suggest some laryngeal edema, and that feeling of tight chest as well. And that could be breathing difficulties there as well. So treatment, first line for anaphylaxis. So Tom had a very good situation. His teacher administered his adrenaline auto-injector, which he had at home. And actually, after 5 minutes, started to feel much better. So this often, our patients sometimes will give their adrenaline auto-injector and they do feel better soon. But really, really important is the what to do next. And that's to call for an ambulance. The patient needs to go to hospital by ambulance. Our local ambulance authority will guarantee an ambulance dispatched within 8 minutes for those cases of anaphylaxis. So really important when you're educating patients to say, make sure they say that it's anaphylaxis. He had the opportunity to get some antihistamine as he was feeling better. So that's really important in terms of treating the allergic reaction as well. And he's asthmatic, so he was feeling tight-chested. We need to give him 10 puffs of this albuterol straight away to open up the airway. Now, he needs monitoring in hospital and 6 hours. So I pose a question as to why we do think 6 hours. And that's really important, is that some patients can go on to develop what we call a biphasic reaction, where after the adrenaline starts to wear off, they can get a secondary reaction there as well. And so it's really important that they have some monitoring in hospital for a good period of time to see that they're not going to be one of these patients. It is a rare occurrence, but if it happens, it can be quite scary if you've sent your patient home. So this study, although a bit old now and probably needs revisiting in terms of certainly some of this criteria now, which I think has changed since that time. However, fatal anaphylaxis is still a problem of young adults. So it's children into this age group was suggested between 8 and 35. Always involving asthma, and still all of those fatal anaphylaxis we've seen all over the news, it's always involved asthma. Used to be peanut allergy used to be a problem. I certainly see now in most children I see with anaphylaxis, it tends to be things like milk and egg, and adolescents, we tend to see things like cashew nuts now, and sesame probably more often than peanut, and fish obviously in adults as well. It seems to have a female predisposition. Having said that, I see a kind of mixed picture of children that come into our clinic. It usually involves food outside the home, and in children, it's thinking about those caregivers as well. So grandparents are still the enemy out there and still the #1 killer, and they don't believe in allergies. And so it's really important, that whole family education. And then eating out of food as well, is making sure that patients are educated on how to look for allergens and to look for allergy menus in terms of managing their allergies outside the home. In all cases of fatal anaphylaxis, unfortunately, delayed adrenaline administration is nearly always there. And that's why I always say to our patients, give your adrenaline if you're in doubt, because it's better you have it and not necessarily need it than wait, because delayed administration of adrenaline is always associated with a poorer outcome. So when we think about treating an allergic reaction, we go for our airways and breathing and circulation. And if that's abnormal, adrenaline, bronchodilator, and call for help. Obviously, if that's normal, you want to be thinking, if it's just a rash, just swelling, and then you may just want to go for antihistamine. There is a nice guidance on anaphylaxis and how we manage that within a hospital. And so these are some of the things that we recommend if a patient attends with anaphylaxis. So certainly thinking about how it's occurred and what has occurred before that is really important, and what they've been doing, what they've been eating, and that record time of onset is really important as well. Anaphylaxis occurs quickly, so if it's a delayed presentation, this may not necessarily give you some red herrings. Where we've got anaphylaxis because of venom, drug, or if it's idiopathic in nature, a blood sample for a serum tryptase is really important. Tryptase is one of the hormones that is released when you're having an allergic reaction. So it's really important that then a secondary sample is taken a few hours later to confirm that there's been that elevation during anaphylaxis, and then that can confirm that for you. Really, really important, these patients are referred on. So if they've had anaphylaxis, they need to be treated. They need to then be given an auto-injector to have at home pending investigations. And that can be a referral onto an allergy team, be a pediatric or adult allergy team. But that in some areas that may be managed by a general pediatrician or a general medicine. And so I think it's really important that they have some referral on for someone who's going to manage that there as well. If you've got some education and information to give them, so much the better. There's resources such as Allergy UK are fantastic for referring patients to for information on dealing with their allergies as well. And obviously you'll have local referral pathways as well. So a patient who's had anaphylaxis should have a rescue package to have at home, and that would always include antihistamine, and we always recommend a non-drowsy antihistamine. If they've got asthma, they should obviously have their bronchodilator as well, and then an auto-injector, but really importantly, they know how to use that. So our management principles would be that they would obviously avoid the allergen, and that does need some support, especially with food allergy, that they've got some dietetic support there as well. And that they've had recognition and they know how to recognize and treat an allergic reaction should it happen again while they're waiting for that all-important appointment. Patients with anaphylaxis should have really good control of their asthma as well. So majority of episodes occur in the community, which is why education is really important. And it's not just thinking about the patient themselves. If it's a child, thinking about their parent, teachers in school, carers, and be that grandparents or childminders, but also for adults as well, thinking about friends that you may be out with more often, or people in the home. Obviously, patients should all have an individual management, and I'll show you those shortly, and obviously that emergency kit that's to hand and in date. So there are some now consensus plans that we use across the UK. So these are available on the British Allergy Society website, the Royal College of Paediatrics, the Royal College of GPs, and both charities, Allergy UK and Anaphylaxis Campaign, have them available as well. And so these can be the patient, we can fill this in with all patients' details, and it gives a clear guide on how to treat their allergic reaction as well. So it's really important that we give regular training. So in both healthcare workers and also for our patients, in this study where they were looked at physicians who are having training of auto-injectors, found that the skill and knowledge decreased after 6 months. So we're giving training on a regular basis. So 3 months seemed to be the optimal. And again, we know that proper training increases the awareness of carrying auto-injectors and their use as well. So making sure that our patients are educated at least once every 6 months. Now, this is where pharmacy could really help us. So we certainly don't have the capacity within the hospital to be seeing patients every 3 months for these auto-injectors, but actually when this study from the Netherlands looked actually at pharmacists and how they delivered adrenaline auto-injector training. Now, 84% of those pharmacists felt that they were responsible to deliver some education. But actually out of those 84%, only 50% did. And unfortunately, in this study, no one did it correctly either as well. So really important that you're knowing what to do, and so you can educate patients correctly, but also it's good to see that so many people felt they were responsible in delivering this education. Now, pharmacists are vital. They're often there at the point of replenishment of prescriptions. So auto-injectors have a varying shelf life. If you speak to the companies, it's 2 years, but actually in reality, most patients, it's 12 months really at a max, occasionally less, and occasionally often more than 12 months. But actually, if there's a thought that actually this would be a good time to think about education. If we can offer that at point of renewal, we know that this will be beneficial. And certainly the education for pharmacists was found that if they had regular education, this was found to be beneficial in terms of training. So attending a fantastic training day like today, where we can go through those adrenaline auto-injector, just give you that education. But then thinking about if you're not doing it on a regular basis, then perhaps every few months, just refreshing your memory on how to use those so you can educate your patients well within the pharmacy. So in the UK, we've 2 pens on the market. EpiPen, which is the kind of brand that most people are familiar with the name, but actually Jext has been around for a number of years, and in certain areas that's the majority pen that's used. Emerade was also available, however, that has now been withdrawn by the MHRA. So if you do come across a patient with that they should be switched to an EpiPen or a Jext pen. So there's also a government scheme now about spare pens in schools, where if a patient has a plan to involve adrenaline auto-injector, a school can have a generic pen in school. This was launched not long before COVID struck, and there was an adrenaline auto-injector shortage for a little while as well before COVID, which has not really, so not many schools have implemented this, but I think now as things start to return to normal, whether this will start to come forward. So schools can purchase a generic or adrenaline auto-injector now from pharmacies, and there's some reference there for some information. There's also some on the Allergy UK website. So we've got a demonstration now. So this is what a live EpiPen looks like. So it comes inside a tube, and this is what we'll see with the device. I'm going to go through the individual devices now. Both companies can provide you with training packs and training pens to have in your pharmacy, and these can be given out to patients. Patients can equally register on the websites of both companies to get a demonstrator pen for them to have at home, so they can train their family as well. So with Jext, as with both pens, you need to lie the patient down with their legs slightly elevated just to keep their blood pressure up. And then the difference with between Jext and EpiPen is both of them have a safety cap which you'll have to remove. So with Jext, it's a yellow cap that's removed. And then the next step will be putting the narrow end of the auto-injector to the thigh and pressing in until you hear the click. Once you've heard a click, that will be the needle firing in, hold for 10 seconds, and then remove that. You can massage the site then to get the adrenaline going, but that's a one-use only device. So if it's been taken out too quickly, or it's you've not done it properly, that device can only be used once. Obviously, as we've said before, call 999, ask for an ambulance, and really important to state that this is anaphylaxis. If there's no improvement after 5 minutes, then we give a further dose. EpiPen, exactly the same. So lying that patient down, and now with EpiPen, you've got a blue cap. So they always say blue to the sky, orange to the thigh, just so it's a bit easier to remember. Now, the difference with EpiPen is you need to have a bit of a swing in. So both devices can actually be given the same way, but this is the manufacturer's guidance. So I'll tell you the correct way, which would be just to swing it into the thigh, hold, make sure there's a click heard. Now with EpiPen, the company suggests it's only 5 seconds required now. I've not changed my training with patients. I still tell them 10 seconds, just because there have been so many problems with supply of these pens. A patient may have one or both of the pens in their possession, or they may have a switch in prescription. So I just tell them to hold for 10 seconds, and we know then if they've got the Jex pen instead of the EpiPen, that we know that they've kept it in for long enough. So, and after 10 seconds, you take off, and then you again massage the site to get the medicine working. Exactly the same principle. Call 999, state anaphylaxis, and if there's no improvement after 5 minutes, give a second dose. So in summary, anaphylaxis is best prevented, but the only recommended treatment is adrenaline. And I think if a patient presents to you in pharmacy, it would be great that they could be offered some training at that point as well, but also ask that question, are they under an allergist? Have they seen someone for their allergies, or have they just been to A&E? And then there's a potential there that we can ask their GP to then refer them for further treatment. For pharmacists who are interested in allergy, in Newcastle, I'll do a shameless plug that we have an online postgraduate module that runs for 13 weeks, which is at master's level, but covers all things allergy, and that will get you points towards a master's if you're doing one. And thank you. Any questions? I'm happy to be contacted. And for those of you that are on Twitter, I'm also present there. Thank you very much.
I hope that you've enjoyed this afternoon's webinar and found it to be a valuable learning experience. It has been a pleasure to have you join us. Please remember to complete your participation survey. This will help us evaluate and improve future events. And as a result of doing your survey, you'll also receive a certificate of attendance for your CPD points. As we said, a recording of this webinar will be available in due course on the Allergy UK website, should you wish to revisit any of the presentations and listen to James's presentation as well. As this event draws to a close, I'd like to say a big thank you to my colleagues at Allergy UK who work with such enthusiasm and dedication on events like this to ensure they're delivered successfully. And also a big thank you to today's speakers who have taken time away from clinical practice in their busy roles to share their knowledge and expertise. Thank you also to Sarah and Catherine from Attendable, who've supported us today with the tech side of this webinar. A big thank you also to our sponsors, Novartis, Nutricia, Thermo Fisher, and the Arteris, who make these educational events a possibility. Just like to share with you the rest of our webinar series, which is 3 future events on food allergy, chronic spontaneous urticaria, and allergic skin disease in October, November, December. We hope that you will be able to join us for one or more of these events, and we wish you well. Thank you very much for joining today.